Good morning, everyone. Hello. My name is Keady Zaman. I am a Health and Wellness Program Coordinator at the Tribal and Rural Opioid Initiative. And on behalf of the Tribal and Rural Opioid Initiative and Utah State University's Office of Health Equity and Community Engagement, welcome to the 2021 Intermountain Tribal and Rural Opioid Wellness Summit. We are so proud to present you with a great lineup of educators, industry experts, local healthcare and community leaders, and special guest presenters who will talk about some of the most current and pertinent topics surrounding stigma, harm reduction, and substance and opioid use disorder prevention, treatment, and recovery, as well as strategies to help build recovery-ready communities. This year's summit is sponsored by the Utah Department of Human Services, the Rural Health Association of Utah, Utah State University, USU's Emma Eccles Jones College of Education and Human Services, the Department of Kinesiology and Health Sciences, USU College of Humanities and Social Sciences, USU Extension, and SAMHSA. Now I'm going to turn it over briefly to my colleague Claire Warnick, who will go over some housekeeping.
Good morning, everybody. We're excited to have you join us today. I'll try to be brief with the housekeeping. I know it can get a little tedious, but I did want to make sure everyone's on the same page. So for our morning sessions of the summit, we will be using the Zoom webinar software, which is a little bit different than Zoom meetings. I'm assuming most people are pretty familiar with Zoom meetings at this point, but because we're in the webinar setting, participants will not be able to unmute their microphones or turn on their video cameras during the morning sessions. At some points, if presenters have a Q&A session of their presentation and they would like to take questions verbally, you can just click the raise your hand option on Zoom and the panelists will turn on your microphone for you so we can hear you verbally. Otherwise, our chat box is open. You'll be able to send messages to all attendees and to panelists and attendees, or just the panelists. You will not be able to send private messages between attendees, I don't think, during the webinar session, but during our afternoon breakout sessions, you will be able to have kind of a more interactive experience with other attendees and presenters there. We also have a Q&A box open, which please feel free to use as much as you'd like. Those questions can be submitted anonymously if you would like, or you can leave your name associated with it. Those questions will be directed to presenters and they can either answer those verbally or respond in the chat. Once the questions have been answered, everyone will be able to see the questions, but until the question is answered, those will be private to the presenters. Our summit sessions are all being recorded. I'm sure you've heard the notification when you joined the meeting today, and may be used in future for maybe rebroadcast or shared at some point. If you would like to remain anonymous, please do make sure that your Q&A questions you check the anonymous box. In the afternoon breakout sessions, we will have instructions on how to change your screen name or turn off your video and your microphone if you would like to remain anonymous in that recording as well. Poll questions, if there are any, will have anonymous answers. So just want to make sure everyone is aware of what is being recorded. Our schedule for today, this morning, we will have our opening keynote sessions. We will have a couple of different lunchtime activities from about 12 to 1, 12:50-ish p.m. Mountain Daylight Time. And then in the afternoon, we will have two different breakout times, one from 1 to 1:50 Mountain Daylight Time and one from 2 to 2:50 Mountain Daylight Time. The breakout sessions and lunchtime activities will be held in separate Zoom meeting rooms. So please have your reminder emails pulled up somewhere so that you can double check the links to all of the sessions. We will also be putting the links to the sessions in the chat box here in this webinar as we approach the end of this morning's sessions. We will also leave the webinar room open during those sessions in case you have questions and need to pop in or need some further direction. Will be available then as well. All the handouts for the summit can be accessed on our website. We'll put the link to that in the chat box, as well as the link back to this main session in case you need it again later. During the morning sessions of the summit, we will have a peer support room available in case you would like to talk to anyone about the topics under discussion in the presentations, or if you just need to chat. Those will be available from 10 a.m. to 1 p.m. Mountain Daylight Time, and we will put the link to that meeting in the chat as well. The sessions in the peer support room will not be recorded. Those will be confidential. So please feel free to use that resource if you would like to. And then just a reminder that at different times during the summit, you may be asked to fill out some evaluation surveys. Please do take the time to fill out those evaluation surveys. It's very helpful for us to know how we can improve our programming and to know how we're kind of meeting the needs of attendees so that we can continue offering resources like this conference today. We are also offering CEU credits for attending this conference. Instructions on how to request CEU credit documentation will be given out at the end of the conference and in our follow-up emails as well. If you have any questions about the announcements or housekeeping or Zoom or any of that, please feel free to put those in the Q&A box. And then finally, we would like to hear from you a little bit as we get started. So please feel free to put in the chat kind of where you're joining us from today, and then also one thing that inspires you as we kick off this great conference. Thanks everybody, and I'll turn it back to you, Keady.
Thank you, Claire. If you have questions at any time, feel free to reach out to myself or Claire or Jennifer Petrus. We're here to troubleshoot and support you. Now it's my pleasure to introduce our keynote speaker today, our opening speaker today, Dr. Sandra Sulzer. She is the director of our office, the Office of Health Equity and Community Engagement, and she's also the co-founder of the Tribal and Rural Opioid Initiative. She has a Ph.D. in sociology and community and environmental sociology from the University of Wisconsin-Madison, with a specialization in medical sociology and social psychology. She completed a health services research postdoc at the University of North Carolina, Chapel Hill, and an integrative medicine postdoc at UW-Madison in the Department of Family Medicine and Community Health. Sandy is faculty in the Master of Public Health program at Utah State University, where she teaches public health communication and holistic health. She was hired at Utah State University in 2017 to launch health and wellness programming within Utah's cooperative extension system. In that capacity, she has had the joy of visiting every county and meeting local, state, and national change makers, and working with an incredible team of people who inspire her every day. Thank you, Sandy. I'll hand it over to you.
Thank you, Keady. I'm so excited to be here with you all. I'm going to do the awkward screen share bit here so I can start my presentation. So bear with me, please. All right, everyone should be seeing a screen now that says opening remarks. And I'm going to count on my team members to nudge me if that's not the case, because it won't be possible for me to view the chat while I have this up. Okay, so thank you for that very generous introduction, Keady. I'm not going to try to talk for too long today because I really want us to dive into the summit. I'm so excited for us to be here. But welcome, everyone. I am here mostly just to give you a quick preview of what extension is, to kind of situate who we are at Utah State University, a land-grant university, and part of USU Extension. So if you're already familiar with this, I promise it'll be brief. And if you're not familiar, this is going to be great information for you, because wherever you are in the country, there is extension near you. So this is an old graphic from USU Extension, but I like to use it because this is the graphic from before health and wellness was initiated as a major category in the extension system. So historically, extension in Utah covered things like gardening, food and nutrition, 4-H, youth, and so on, agriculture. We have offices in 28 of the 29 counties, 4 gardens and centers, and you'll notice that it says 55 extension county experts. Those are people that live and work every day in those 29 counties of Utah. And then there are 45 of us who are based on campus. Every year we offer hundreds of classes and events, how-to guides, publications, and instructional videos. So what on earth does Extension have to do with health outreach? Well, all of this began with a vision. So the Extension model arose at a time when American agriculture was new and marginally productive. And a century later, agriculture is without equal in contributing food to a growing world population. So the National Extension leadership in 2014 said, well, wait a minute, we should be using Extension to do for health what we did for agriculture. So that was the vision. That vision sounds amazing, but it's a really big vision. And so then the question remains, how on earth do we do that, right? If you have a public health background, you know we always begin with a needs assessment. And our particular team, the Tribal and Rural Opioid Initiative, we use, this is a mouthful, but we use a community-based participatory action model. And to sum that up in layman's terms, that means you tell us what you need. You tell us what you need, and then we work to support to help make that happen. So across the 4 years, I was hired about 4 years ago, and I was the first official health and wellness position, but I do want to acknowledge that there have been people in Utah doing this work for years, including my colleague, Susie Prevedel, who is hosting this event with us, Cindy Nelson. There have been people in Utah doing health and wellness always, but as far as it being an institutional formal priority outside of nutrition and food and so on, it's really just been about 4 years. And these are 4 major programs that have come out of that time. So you might be familiar with the HEART team, for example, or you might be familiar with the Robert Wood Johnson Connected Communities Initiative. Maybe you've never heard of any of these things. That's okay too. The Master Health Volunteer Program allows everyday community members to get training in health and wellness and return 40 hours of service in their community and grow health and wellness through volunteerism statewide. So what are some highlights? For all of those big teams and groups and projects I just mentioned, each of them, just like the original slide, are giving hundreds of presentations, outreach. So a few highlights: the Debunked podcast later this week. Oh, it looks like we had a little technical glitch, so I'm going to pull this back up here. Later this week, you are going to see or have the opportunity to sit in a Debunked podcast live session. Let's try this again. All right. We also offer free naloxone trainings, which we've been doing online during COVID. And really importantly, these are culturally centered trainings, and they're available nationwide. The Tooele Rural Opioid Healthcare Consortium has this beautiful new website, so I wanted to feature that. There are so many things happening, so this is just a very, very brief overview, but speakers from all of these groups will be available this week throughout the summit. So as we move into this space of being extension-based and being a land grant, we do have to take some time for acknowledgements. So the 1862 Moral Land Grant Act is what set aside land for universities like Utah State, and ultimately later led to the creation of cooperative extension through other legislative enactments. That act redistributed, and I have this in quotes because we're gonna have a real talk about this, redistributed nearly 11 million acres of land, roughly the size of Denmark, but within the United States, and worth roughly $500 million. This act was not bloodless. Eastern schools where there wasn't land available, so every state got about 30,000 acres. So in a place like Delaware where there wasn't 30,000 acres available, those schools, those states got land out west. So a lot of Eastern and Western schools got land in the South and the West. This led to 160 violence-backed land sessions. And session is just a fancy word for when it's at a state level, that taking of the land. 250 tribal nations had land taken from them. And so a lot of universities are working toward a space of acknowledging where we come from and how this legacy impacts our work. Colorado State University, as we're the Intermountain Summit here, now includes a statement on its website that our founding came at a dire cost to Native nations and peoples whose land this university was built upon. This acknowledgement is the education and inclusion we must practice in recognizing our institutional history, responsibility, and commitment. Unfortunately, if you think that an act from the 1800s is very, very far in the past, I just do want to take a moment to emphasize that profiting continues to this day. For example, New Mexico State earned $1.6 million in 2019 from the leasing of its land, and over 13,000 of those acres came from Navajo Nation. Anyone familiar with public health work, and maybe everyone in the nation, is aware that from a public health perspective, the Navajo Nation has faced a very difficult battle with COVID. And so when we think about millions of dollars that are profiting someone else that originally came from tribal land that's then no longer available to the tribes as they face whatever they're facing with resilience and strength. Again, that's an ongoing present reality. It's not just something from the 1800s. I do want to share some bright spots. So South Dakota State University established the Wokini Initiative, which translates to new life or new beginning. And it is a strategic reinvestment of those land grant funds back into American Indian student success and Indigenous nation building. So as a faculty member at Utah State University, a land grant university, who has a role in cooperative extension, I know I come to work every day keeping information like this in mind. And I want all of you to keep this information in mind as well, because as our nation reckons with its complicated history, we at land grant institutions need to acknowledge our legacy and that we were created at a dire cost to Native nations and peoples. And so I love this quote. It says, "Doing so and working with Native peoples to address current issues will give these great institutions a powerful legacy of which we can all be proud." So as I gave this very, very brief cursory overview of the history of extension, all the great things that it does and is capable of, but also the uncomfortable history of how we were founded, whatever that brings forward for you, whether it's discomfort, whether it's anger, whether it's sadness, frustration, bring that to the summit, because we need all of you. We need your authentic self coming forward to face these issues as we find our way forward. And I do want to highlight just a few of our speakers who are going to help us keep moving this conversation forward. Later today, we have Dr. Patrick offering a session on strategic communication. Is that a thing? Tomorrow at 12, we have a trauma healing art workshop. I invite you to take a look at that, as well as our Indigenous Prevention, Treatment, and Recovery panel. And on our final day, I know I already mentioned this briefly, but we'll be hosting a Debunked podcast live, wherein we are explicitly going to talk through how Indigenous and non-Indigenous groups can work together to solve social problems. So for those of you who would like to learn more about what I spoke about, this next slide just has a few additional resources. I kept it to one scholarly source to keep it light for you, but this will be available to all of you as attendees. And you can also reach out to me personally if you would like to learn more about this history or access to other resources. So Utah State University is currently working on its acknowledgement statement. So we'll be looking forward to seeing what that looks like. And now I am going to hand it back to Keady Zaman.
Thanks so much, Sandy, for your comments and your leadership. It's really a pleasure to work with you. Now I'm going to introduce Dr. Cris Meier, who is an assistant professor in the social work department and an extension community resource and economic development specialist at Utah State University. And I've also enjoyed working with you, Cris. Cris is going to introduce our keynote speakers.
Thanks, Keady. Yeah, I'm really excited to have been invited today to introduce our wonderful keynote speakers. We're thrilled to welcome Megan West and VaRonica Little, who are both representing the Utah Department of Health Services. So I'll just briefly introduce each of them so you can kind of orient to their background. So Megan West is an opioid grant program administrator with the state of Utah, Division of Substance Abuse and Mental Health. She's the co-chair of the Access to Treatment Work Group under the Utah Coalition for Opioid Overdose Prevention and Alternate State Opioid Treatment Authority. Megan is also involved with the Utah Society of Addiction Medicine, a chapter of ASAM consisting of addiction medicine providers throughout the state. She is currently pursuing her master's degree at the University of Utah in Public Policy and is a member of Salt Lake County Arts and Culture Board. Megan's summer goals, I especially enjoy these, are to get her motorcycle license and work on her green thumb. So welcome, Megan. And then we have VaRonica, who's also presenting today. VaRonica Little began working in the field of substance abuse and mental health 17 years ago and has worked with a variety of populations and in multiple settings. She earned her master's degree in social work at the University of Utah and is focused in the areas of trauma and addiction. In July of 2017, VaRonica accepted a position at the Division of Substance Abuse and Mental Health to oversee the federal grants coming to Utah related to the opioid crisis. Since being hired, she has overseen 3 federal grants and has become the state opioid treatment authority for Utah. She sits as co-chair for the Utah Coalition for Opioid Overdose Prevention Steering Committee and participated on many task forces and coalitions to connect and partner with communities and providers who are focused on helping Utah effectively combat addiction. VaRonica believes that substance use is a chronic relapsing brain disease that affects all aspects of an individual's life. Recovery is a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. She believes this disease requires holistic support, education, options and opportunities, multiple interventions at different levels of intensity in order to affect long-lasting change. There's no wrong path to recovery. So with that, Megan and VaRonica, thank you so much for joining us, and I'll hand it over to both of you.
Thank you for that, and hello. We're excited to be here. Good morning, everybody. We are honored to be able to participate in this amazing event, and I hope that we can provide some information and insight for you all. Some of the stuff you guys might already know, so I'm not going to get into really deep into the woods on any of it. We're just going to do a brief summary and overview. I just want to start out by letting everybody know that really we don't have any disclosures or anything like that that we need to share. We are only employees of the state of Utah, but we do have amazing partners that we want to recognize. And so I always want to point out in any of our slides with data, any of the information, we try and attribute it to where we got it. So whether that's the CDC at our national level, whether it's the Department of Health, Medical Examiner's Office, if there's ever any questions, feel free to email me or Megan, and we can help direct you in where we got the information. Go ahead and go to the next slide. I always try and come up with really great things to share with folks, but I realize I am not good at that. So I just borrow what other people have said. And I want to share with you all that my true belief with everything that we do in this world is that we cannot do anything alone. We are not our best selves until we are working with others to be their best selves. And this applies especially with the opioid epidemic. So I wanted to start us off on the right foot that way. Next. There's a lot of information out there. I don't know how many of you guys feel this way, but at times I just get overwhelmed with all of the information, with all of the data that comes through, and I'm not always sure what's going on. So I wanted to break things down really pretty basic. When we're talking about the opioid crisis, there have been 3 clear distinct waves that we have seen throughout the nation. The first one really came about when we saw prescription opioids taking over the prescriptions, the things that we were getting from our doctor's offices, and addiction came on really hard for many people. The second wave started coming when we saw that people weren't able to maybe access those opioid prescriptions like they had in the past. They turned to illicit substances such as heroin. A lot of people just call them street drugs, but we found other ways to get our drug of choice and the thing that we physically craved at that point. And then there's this third wave that started hitting with synthetic opioids. Many of you have heard of them called like fentanyl, carfentanil. These are scary on a whole new level because of how potent they are. The overdoses have increased, skyrocketed really based on this third portion of what we have seen throughout our nation. And it's really taking its toll and it's continuing. When we look at 2019 data, which is the latest we have from the CDC, there were over 70,630 overdose deaths in our nation, and 70% of those involved opioids. It's hard to see and hard to talk about. It's hard to feel and experience this, but we need to be clear and we need to be open and honest about what's going on. Opioids are killing people. There are a lot of substances out there. There are a lot of things that are dangerous and damaging, and opioids kills really fast. When we look at the overdose rates, the rates that we have in our nation, they've quadrupled since 1999 when it started being tracked. Go ahead and go to the next slide. As a nation, again, all this information comes at us really quickly, and some of it can be really confusing. Historically, Utah has been one of the highest in opioid overdose deaths in our nation, and that's since 1999 when they started collecting the data. In more recent years, we've kind of leveled out. One of the things that I oftentimes want to point out is we are doing some good work. We also don't really have a big handle on what's going on. We've been lucky in Utah because things have kind of mellowed out for us, but it's because we're behind some of the other parts of the nation where things have hit a lot harder and a lot faster. We've improved, yes, but we still got a long way to go. One thing I want to always talk to people about is when we're looking at rates of death, when we're looking at percentages or the ranking throughout the nation of where we're at, Utah has now decreased. We're about 24th in the nation for opioid overdose deaths, but I want to also point out that there are going to be times that you hear statistics thrown out there. It's provisional data. What that means is we aren't exactly sure on the counts. They're our best guess at this point, but nothing's been confirmed. When we talk about preliminary timeframes, it makes small changes a lot bigger. We know that there's a problem. We know that things have impacted it, but we don't always know when and what that timeframe looks like. So as we continue to look through and we really dive deep into that data, make sure that you're looking at it holistically and realizing that spikes happen. Things kind of go up and down like this. And if we look at it in bigger chunks of time, especially year timeframes, we see that things typically stay a little bit more stable than what we hear. Go ahead and go to the next slide. In Utah, though, I do want to point out that we do have some differences from most of the United States. One of the ways that we are different is that we are still really high in prescription opioid overdose deaths. It's really interesting when we look at things historically. Right now, 51% of our controlled substance database is because of opioid prescriptions. Any scheduled medication, that's a benzo, it's a stimulant, it's an opioid, all of those things are tracked into the controlled substance database, but 51% of them are still opioids. The rates of dispensing throughout Utah has definitely gone down. I think that we are all doing our part to try and make sure that we aren't overprescribing, that when we are talking with our doctors, when we are in need of something, that we are using it responsibly and that we are getting the education that we deserve to understand what we're taking and how it could possibly affect us. The prescribing rate currently in Utah is 51.4 per 100,000. So what that means, or per 100. So what that means is for every 100 people, there are 51 opioid prescriptions in Utah. That doesn't mean that just half of us just randomly get them. It means that based on our population, that's how we can break it down to really get a good grasp of what that looks like. That has decreased in the past 5 years, which is really awesome. At our peak here in Utah, our prescribing rate was 91.3 per 100, and that was in 2008. We've done a really great job of decreasing those prescriptions, but we also don't want to leave people in a lurch. If somebody is in pain, if they need medication, they should be able to get it. So we're doing a lot of things to try and educate and encourage our communities to prescribe responsibly, to be able to store medications appropriately, and to talk about alternatives to medication if that's an option. Go ahead and go to the next slide. There's a lot of information again, and the data kind of gets overwhelming at times, but I think that it is absolutely important to look at what the overdoses specific to Utah look like. So again, I want to be clear, this is information from our medical examiner's office here in Utah, and the 2020 data is still preliminary. That means there's a few out there that are still in with toxicology. But I think that it is good to look at what it has looked like for the past 3 years. The rates that are going across, as you can see, 2018 is in blue, 2019 is in orange, and 2020 is that gray line. There have been fluctuations and changes. And overall, when we look at the overdose deaths in Utah, they really have stayed fairly stable. for the past 3 years. One of the things that was interesting is that we had a really good decrease in overdose deaths at the end of 2019, the beginning of 2020. Those rates went down, which is an amazing thing. And we want that to continue. We were hoping that that would continue. So we did see an increase in 2020, but really what that did was it brought us back up to the numbers that we had seen previously. They didn't skyrocket past that. Any death is too many when it comes to overdose from drugs. And we don't want to downplay the losses that we have experienced, but we also want to be realistic and not cause panic. When we're looking at the types of deaths that have happened in Utah, one thing that we can point out very clearly is that the prescription overdose deaths have decreased. From 2018 till now, it's decreased about 15%, which is still good. We are making that, good decline. Illicit substances such as heroin, those have also decreased, but it's just not as drastically. What's the difference then? What's going on in Utah, and why are our numbers really not plummeting altogether then? Go ahead and go to the next slide. Here comes that big scary thing that we started talking about earlier, and that's fentanyl. The fentanyl numbers in Utah have increased drastically since 2016. Historically, we've had fentanyl in Utah, but it's really just been at really small amounts. About 8% of things overall have included fentanyl overdose deaths, but that has changed, and it's very, very scary. From 2018 to 2019, the data shows about a 32% increase for fatal overdoses involving fentanyl and fentanyl analogs. It's a lot, and it's really scary. And some of those are from prescriptions, but most of them are not. It's being put in a lot of different substances that we have here in Utah that people utilize. And so what this graph shows, and what I wanted to point out to people, is that it isn't just fentanyl that's killing people. Oftentimes it's really the combination. And I think something that many people don't acknowledge or understand or see initially is really that fentanyl is in lots of substances. It's not just in heroin. It's not just in something that looks like a pill that you're taking. It really can be in anything. And so the yellow line here is fentanyl and any prescription opioids. The blue line is fentanyl and heroin. Orange line is fentanyl and meth. Gray line is fentanyl and benzodiazepines. And the green line is fentanyl and cocaine. The numbers for fentanyl being in heroin and cocaine are lower. And so some of those numbers are estimates because the counts are so small, it's not appropriate for us to share. It could possibly identify individuals, and we don't want to do that. But I think that it is important to see those huge spikes from 2019 to 2020, especially with prescription opioids, especially with meth and with benzos. These combinations are deadly and they kill people quick. We want to make sure to educate people. Don't want to have scare tactics. We know that those don't work, but we want to ensure that people understand and know what's out there, what the possibilities are, and really the potential fatal outcomes. The fentanyl seizures that have happened in our state through our law enforcement have completely skyrocketed. It's insane to me to think, but the submissions to our crime labs of fentanyl analogs increased by 129% from 2018 to 2019. And in 2020, we just saw those numbers increasing. We need to be cautious, we need to be careful, and we need to be educating our communities about this very dangerous substance. Go ahead and go to the next slide. So this is the question that everybody keeps asking, and I think that it's really an interesting one. What have been the impacts of COVID-19? So when I was thinking about this and we were preparing to talk with you all today, it became an overwhelming task to look at what all has happened since really we all started hearing about COVID-19. So I went through and started putting together just some of the major events for here in Utah. Our first one was in January, when really the first confirmed case of COVID hit the US soil. That hit a lot of people pretty hard, especially in the health community, when we were being notified of what was going on, what that might look like as we move forward. I'm sure there are some people who hadn't heard of it at all, hadn't really thought about it much. But on March 6th, the governor issued a state of emergency. This changed a lot of things for people, probably many of you here in this summit, and it has continued to impact us differently. I don't want to downplay anything that anybody has gone through, so I hope to be respectful in the things that we are continuing to talk about as we move forward. On March 11th, 2 of the Utah Jazz tested positive for COVID. And I think for some, that really made it sink in, like, oh, we're not immune to this. This is something that could absolutely happen. These people seemed perfectly healthy and fine. It raised a lot of anxiety for people. On March 13th, there was a soft closure of all of the K through 12 schools. I'm a parent of 2 young kids. And I'm going to tell you that this was the point where I started panicking. I was like, crap, how am I going to keep working? How are we going to do this virtual school? I'm fortunate enough to be able to have some of those resources where it didn't impact everything in my world, but it definitely makes a change. Everything really started to sink in. Again, there are times for everybody that are going to hit differently. And that was the big first real major one for me. March 18th. Those of you who are outside the Wasatch Front might not have experienced this, and I am so grateful for you. But there was a very large earthquake here in the Wasatch Front, a 5.7 magnitude earthquake, and we continued to have aftershocks. There were 2,589 aftershocks experienced here in the Wasatch Front within a 2 or 3 month period. I remember being on some calls and in a Zoom meeting and having my camera shaking and a national partner saying, what is going on? It was a real big impact for many people. Others, it just kind of blew by, didn't make much of a difference. On March 22nd, we had the first death in Utah based on COVID-19. April 5th, there was a big change and the Navajo Nation instituted a weekend curfew. The full impacts of how much a community can be hit by this virus really took hold. And I think that the people here in Utah started really taking notice and understanding that there's not a way that we're really going to get around this. April 18th started day 1 of 156 stretch where wildfires ravaged our state. On May 30th, protests escalated in Utah and the National Guard was deployed. All of these things are happening while we are still trying to live our lives, while we are still trying to work. Some of us lost jobs. Some people had homes that they could no longer stay in because of financial burden. There were businesses that had to shut down. There's been civil unrest. There's limited gatherings. There's the closure of the schools, all of the natural disasters that we had, the earthquakes, the wildfires, and then hurricane force winds later in the year. This is just the first 5 months that we're talking about on this slide. I can't imagine that COVID-19 has not had an impact on all of us and on the opioid crisis, but it's not just COVID-19. There's no way for us to really unravel all of the things that have impacted us in this past year. But what we can say is we have learned from it. We are getting stronger. We are finding ways to adapt to things. Because of COVID-19, we've been able to make some changes both at a federal level and at a state level on what's allowable for medical procedures, medical interactions, for therapy, for reimbursements, for people being allowed to work in different areas and in different ways. Some of those things are really great. Others are really devastating for people. There is a lot of social isolation. I think that when we talk about some of the many changes, we can't gloss over the fact that there are a lot of medical procedures that didn't happen and that people still aren't very comfortable going in and seeking out medical help for things. All of these things, again, impact our overdose deaths, the opioid use in Utah, and how we are all being affected by this. But we need to understand and we need to remember all the things that we've gained. Things have felt a little bit more stable in more recent time when we are looking at businesses opening back up. Some of our kids were able to go to school, some of them stayed virtual. Mask mandates were in place. They've been removed at some points. There were federal and state elections. There has been a lot. And we've also gotten a vaccine now. Taking the time to utilize the strengths and the resources that we have are important. but also asking for help and getting support when we don't have those resources available is important. We won't know the full outcomes of the impact of COVID, of everything that's happened in 2020 for a while. And we're going to continue to look and learn and hopefully implement strategies and resources for people in order to sustain and maintain and prosper.
Okay, I'm going to take over for a minute. So zooming into Utah specifically, a few of the funding sources that the Division of Substance Abuse and Mental Health that our team manages and oversees started with the STR, the State Targeted Response funding, and that was a product of the 21st Century Cures Act of 2016. So $1 billion was allocated to be used by the states to address the opioid crisis. And we received around $5.5 million, and that was a 2-year grant. Then there was some overlap with the SOR funding, and that was allocated to states, and it was another $1 billion. So our newest funding, the State Opioid Response, we call it SSOR to keep it separate, started September 2020, and it will end in 2022, and that was 10.7 million of a $1.5 billion budget by the federal government. So I wanted to show you some of the outcomes from the last funding source, that SOR that ended in 2020, that does have a no-cost extension that's going on. We like to keep things fun and overlapping and complicated. But we do keep track of it, don't worry. So primary prevention is done, prevention of harm, MAT is provided, other treatment projects, recovery, specific support services, and then we have a few other programming. So we have coalitions, money goes to the local substance abuse authorities. There are 13 of those throughout the state. The funding can be used for methadone, buprenorphine, Vivitrol, and SOR was specific to opioid use disorder patients. They could have a primary, secondary, tertiary, and the SSOR newest funding can also help people with stimulant use disorder, which the expansion and ability to help more people is amazing, and we are glad that that expanded with this funding. Peer support, too soon. Grief and loss, tribal projects, insurance navigators with Utah Health Policy Project. So those are some examples of the SOR funding. Many of them continued with the newest funding. So this is the Division of Substance Abuse and Mental Health strategic plans, just a pretty picture to show what we're working on. So again, we have prevention of misuse. A lot of that funding goes through the community coalitions. They know best what their communities know. And that's a big thing with the state. We're not making the decisions. We're working with our partners. We're working with those local substance abuse authority teams to get the funding out. People on the ground know best where the money needs to go, what people need, what the different areas of the state need, because the Wasatch Front is going to be very different from the southern end of the state, or the northern, or the eastern, or the western. So the relationships that we have are so important, and the community providers and with our contractors throughout the state. So what have we been working on? We wanted to cover quickly some of the groups that we work with. And I wanted to start with Caring Connections, Dr. Kathy Supiano, who will be presenting today at 1 o'clock, if you want to join in and learn more. So we have funded the grief support model specific to death from drug overdose with Dr. Kathy Supiano and her team. And it is the format is manuals and trainings. There's 2 tiers. The tier 1 training is provided for professionals who work in a setting where drug overdose occurs. And then tier 2 includes the nature, scope, and experience of grief from drug overdose death and strategies to address it. So it's targeted towards mental health substance abuse agency clinicians, interventionists, direct care staff, the Office of the Medical Examiner, and some hospital-based mental health teams, as an example. It can really be for anyone who has experience and interacts with people who have grief from overdose death. And Kathy and her team do an amazing job. If you are interested in having the training in your area, reach out to her. Our information's at the end of this, so we can either put you in touch with her or join in at one to learn more and get in touch with Kathy. So another project that we work with the Utah Support Advocates for Recovery Awareness, USARA, which is throughout the state. They have 5 recovery centers, one in Salt Lake, Ogden, St. George, Price, and Moab. They have peer support teams in those areas and throughout the state. Specifically, we help fund the ARCHES program, which is the Addiction Recovery Coaching in Healthcare and Emergency Settings, and the CRAFT support model, which is community reinforcement and family training. ARCHES utilizes the peer recovery coaches. They provide individuals with recovery support 24/7 in the healthcare settings. Right now, they are partnered with 9 different emergency departments and 33 healthcare settings throughout the state. The goal is to enhance and expand the implementation of recovery support services throughout Utah. So that's an awesome group. They do a lot of amazing work. And then the CRAFT support model, it's a free program for family members and friends who are concerned about someone close to them who has a substance use disorder. It can be joined at any time. There's no registration fee, no charge for the classes or the materials. And one of the positive things that's come from the pandemic is there's a lot of online options. So you don't have to find childcare. You don't have to leave the house to go to these meetings. You can get online and join in. You can call in. Some of them are in person, some are hybrid. So it just it takes away the barriers, which is really what we're trying to do here, to get people into recovery, treatment, to think about recovery, to get education, and support and connection. Another project is the University of Utah Bridge program. So people can be inducted on buprenorphine by showing up to the University of Utah Emergency Department or the Huntsman Mental Health Institute, which is formerly UNI, and they are enrolled and paid for 30 days in the recovery clinic. So they're inducted, they have therapy, they have group therapy, and then they're referred into the community. So it's a really well-rounded treatment and recovery model. So since the program's inception of April of 2019, 1,663 individuals have been inducted, and that's through the end of April of last month. We work with the Utah Department of Health, American Indian Alaskan Natives, their Health Affairs program. They work to improve how the AI/AN individuals are represented in state data sets. They assess the tribal and urban Indian communities and the relation to stimulant use, substance use, and abuse throughout the state. They've been working on developing education and outreach materials targeted to vulnerable communities on and off reservations. And then they work on enhancing the state reporting on the health status of AI/AN individuals in the state. So it's very data focused, which is great, making sure that people are appropriately represented and they disperse funding and naloxone trainings and naloxone kits, making sure people have what they need and understand and are educated. With the last funding, we had the privilege of working with Dr. Sandy Sulzer, Susie Prevedel, and Michelle Chapus, and they did a great job of getting out onto in the tribal communities and working with tribal leadership to provide naloxone trainings, find out what groups needed and what was lacking, what information wasn't out there that we needed to do better at and get out to the tribal communities. We have methadone in the Salt Lake County programs. Katie's going to cut us off. Naloxone trainings, harm reduction trainings, programs. I'll go quickly. So some advertising that Utah Naloxone does. You've probably seen the billboards across the state. We want to take away the stigma of treatment, harm reduction. People are going to use drugs. So let's make it safe. Let's make it available to have clean syringes, which we do not pay for. We are not allowed to with federal money. Just putting that out there. But clean first aid kits, making sure people are safe. Some examples of the work that the Department of Health is doing. Things that we don't have yet that we'd love to have: mobile methadone clinics, induction at more places than just emergency departments.
So I'm just going to briefly wrap up. I want to make sure that we point out we have done a lot of work, and it's all thanks to the community partners that we have. This is nothing that Megan and I do. We get to work with some amazing folks, some of you out there right now, and those who we haven't had the opportunity to work with, we hope that we can continue to expand and work with you. But really, we also want to acknowledge and be realistic about the things that we still need to work towards. We need to continue to reduce stigma, whether it doesn't matter what substance you use, it doesn't matter how you use it or how the addiction came to be present in your life. When we are talking about recovery, anybody can get there. There's no wrong path to recovery. We need to address chronic pain. We cannot deny that people are in pain and that needs to be treated. We want to keep people safe and we want to keep people healthy. We need to increase awareness and education about substance use disorders in general. Not one substance is the main problem. They are all becoming so overwhelming, and it is difficult for us to maintain and manage a regular day-to-day life. We need to make sure that medication-assisted treatment is available throughout our state. We are going to continue to fight with whatever means possible that we have to ensure that people have access to any care that is medically appropriate and needed. We need to make sure that people have housing. Recovery supports, it doesn't just mean somebody can go to treatment. It means that they have housing, that they can find jobs, that they have some stability in their life to be able to make the changes they want to. That we expand harm reduction. And again, harm reduction isn't just one thing. It's a big multitude of things, and it's a spectrum of life that we have. So we need to make sure we're hitting all of those points. And then again, we need to continue supporting and partnering with our tribal populations and meeting people's needs where they're at. Again, Megan said this perfectly, but we don't know all the answers. You guys have far better understanding of what the needs are in your areas, in your communities. And it's our job to partner with you and to help support you in getting to those needs. And then we want to make sure that we are serving people in all areas, expanding our jail and prison services. Next slide. Really, it's just to reiterate, prevention works. Treatment is effective. People recover. There is no wrong path to recovery. We all have to work together because nobody gets through this alone. If you have any questions, if there are things that we can help support you with, if there's ways that we can improve the things that are going on in your area, please feel free to contact us. Our email addresses are right here. And we are so, again, grateful for you guys allowing us to come and talk with you, presenting just some of the more up-to-date information from our nation and in our state.
Thank you so much for having us.
Thank you so much, Megan and VaRonica, for sharing that information. I really learned a lot. It's really been pleasure, Megan, getting to know you through the planning process. Megan was very involved in helping us put together the summit this year. So thank you very much. So we have about 5 minutes before the session ends to answer questions. If any of you have questions, and I see some of you have put questions in the chat, you're also welcome to use the Q&A box, which is on the lower participant panel. Or you can use the raise hand function and we can unmute you and hear your voice. So feel free to ask any questions at this time. And I've gotten a few tech questions as well. So also if you're having difficulties viewing the presentations, please let me know, or you can also contact Claire Warnick.
So in response to a question that was in the chat, our team is specific to substance use disorders and those funding sources. We're on the team with the youth team, women's and children's team, the suicide prevention is in our DSAMH team. So there's a bunch of individuals that manage different funding sources. So if there's anything that you need or specific information you're looking for, groups for your community, reach out to VaRonica or myself and we can get you the information or put you in touch with the right people.
Wonderful. It seems like the two of you are great contacts to have in the contact book.
If we don't know, we will find it. We're very good at that.
Thank you so much. Thank you so much for participating. We're going to give everyone a few minutes to get up and walk around if they need to before the next session. I hope you'll all come back to join us for Is Your Community Recovery Ready? An exciting presentation coming next. All right. So coming up next, we are excited to welcome Dr. Shawn F. Dorius and Dr. Cassandra Dorius of the Public Science Collaborative at Iowa State University for a special presentation titled, "Is Your Community Recovery Ready?" In this workshop, participants will learn about recovery-ready communities, what they are, why they're important, and how to know if your community is ready to organize and enhance its recovery programming and services. Our presenters will use the Recovery Ready Iowa Research Initiative as a case study to illustrate the process. At the end of this workshop, participants should have a better idea of next steps for moving recovery communities forward in their own area. So I'm going to introduce our presenters. Dr. Shawn Dorius conducts research in social demography, social epidemiology, community well-being, and computational social science methods. Very cool. These days, much of his research effort intersects on substance use with special attention to its social context, effects on individuals, families, and communities, and computational surveillance. His work has been funded by the National Science Foundation, the Centers for Disease Control, the Substance Abuse and Mental Health Services Administration, the U.S. Department of Agriculture, the Bill and Melinda Gates Foundation, and the National Institutes of Health. He teaches courses in demography, international development, research methods, and community sociology. Prior to arriving at Iowa State University, Dr. Dorius was a postdoctoral scholar at the Population Studies Center at the University of Michigan and a research associate at the Survey Research Center in the Institute for Social Research. And then Dr. Cass Dorius is an associate professor at Iowa State University in the Department of Human Development and Family Studies. She earned her Ph.D. in sociology and demography at Penn State University and was a postdoc fellow at the University of Michigan. Her research on vulnerable families investigates how relationships and childbearing experiences shape the unequal distribution of social and economic resources within and between generations. She translates her scholarship into practice through a broad range of state and national collaborations centered on evidence-based policymaking in coordination with early childhood Iowa stakeholders from Iowa's Departments of Education, Health, Human Services, Management, Workforce Development, and Human Rights. She helped to develop an integrated administrative data system for the state of Iowa designed to advance policies that improve the lives of vulnerable children and their families. In partnership with the Department of Public Health, she has worked to advance substance use recovery resources in the state. She co-directed the inaugural Data Science for the Public Good program dedicated to improving Iowa State faculty's ability to work with local communities to solve pressing problems with data. Dr. Dorius serves on numerous state and university boards focused on data quality, community outreach, and evidence-based policymaking. We are so delighted to have both of you here today, and I'm going to turn the controls over to you.
Awesome. That sounds dangerous, but I'm really excited to be here. So thank you for having Shawn and I. We have been working closely with Iowa's Department of Public Health and thinking about this recovery space. And we were very excited about this conference and what you're covering, and hope that we can add to this discussion by thinking about what we've done here and sort of what our pathway has been. But I would be remiss not to start us off by saying, you know, it's really fun in particular to be here in Utah because Shawn and I actually graduated from high school in Utah and grew up there. And then Shawn and I met in Utah and started our family down in Payson. So it's really fun to kind of come back to our roots a little bit. We've been here in Iowa for a number of years, but very much love Utah and are glad to be here. So the first thing we want to do is hear from you because you just had to hear a lot about us and that was probably boring. So this will be a little more fun. If you would grab out your phones and go to www.menti.com and enter this code, we are going to hear a little bit from you. We'll tell you what we think about recovery, but let's first start and say, what do you think about recovery? What is recovery? What does it look like? And this will be the first question that you're asked, which is, how do you define recovery? So again, you go to www.menti.com and use the code 94191118. Oh, let me make sure that the voting is not closed on this. And There we go. We should be good. So I'll put this in chat. And we'll be using this a couple times throughout the talk. So keep it open. And it is anonymous.
If you don't have your phone with you, you can access this through a browser on your computer just as easily.
Okay, it should be working now. So, I've never had the problem where it doesn't. Oh, it is starting. Perfect. And this will just warm us up. And again, it's anonymous. We just want to hear from you. So some of the answers we've heard so far is, how do you define recovery? It's healing, it's collaboration, it's taking back control of your life. It's reducing or stopping use based on your goals. It's well-being and health. It's an ongoing process. It's wellness in mind, body, and spirit. It's getting to a better place for you and those around you. It's making a decision to change something in your life that no longer serves you and sticking to it. Way to go. Abstaining from drugs and alcohol and improving health and wellness. Moving beyond problematic behaviors in your life. An active process of working towards a positive lifestyle. Marriage of peace and control. That's nice. Holistic healing, mind, body, heart, and soul. Consistency in sobriety, making amends, seeking out treatment, and a desire to be well. Learning that I can be healed and overcome and have a life worth living. The process of moving from substance use as a survival strategy, depending on your ability to cope and learning coping strategies. Taking care of yourself, healing and growth. I really love these as they're coming in. I'll keep reading, but I want to point out we're going to come to a theme a few times as we talk today, and that's this idea that there are, we support all roads to recovery. As we're thinking about recovery in Iowa, we want to be really supportive of all the different pathways. And even as we define recovery here, we're hearing some very different sort of things, working past trauma, well-being and health, abstinence, sobriety, control, awareness of striving to live our values. Excellent. Excellent. I'm going to give this one more minute and then I'll go to the next question. But I'm so glad we started with this. These are really motivating to hear what you think about recovery. And this is a goal for us. How do we bring recovery into our states? How do we support it in the people that we work with? Okay, and then we'll go to the next question, which is, we're here to talk to you today about what does a recovery ready community look like? So when you think about communities in your state, or you think about the town or community that you're from, if it was recovery ready, if it was a place that could host and help and support recovery in the way that you think would be best and what you were just thinking about recovery, what would that look like? What do these communities look like that are recovery ready? And then we'll spend the next 40 minutes talking about what we think that looks like. But let's start with you. What do you think that looks like? Oh, supportive, resources for all ages, non-judgmental, excellent. Let's keep these coming. No judgment, we're getting some themes here. Support for all people who need it, non-judgmental, easy access to resources, admit, acknowledge there's a problem, non-judgmental, strength-focused, value of people in recovery, resources, togetherness, interest, not hiding resources and being open-minded. Multiple levels of support available, multiple resources, open, honest, supportive. We're getting a lot of this, open, honest, resources, non-judgmental, empathetic, supportive, growth and support, low barrier entry into the community. Support those in recovery, available resources, resources for all, we're seeing. Teaching about stigma and how to combat that. Community connection, honesty, accepting, helping people move on with their lives. When people start voicing their frustrations about what kind of change they'd like to see, less punitive and more resources, embracing others. Awesome. reducing stigma, working together for change. Now, I feel like that is a slogan. We can make that our love and patience. Lots of treatment and healthy activities available, recognizing the work and willingness to put the resources necessary into the program. Open-hearted, ready to hear and believe facts, non-judgmental, willing to focus resources, people's first language driven. Good. Community outreach. Safe, support for all, educate, no stigma. Clean and sober community with community members supporting each other instead of tearing each other down. Don't hold back resources. Resources with 3 exclamation marks. Togetherness. Excellent. Okay, so what we learn here is you have a pretty good idea of what these communities would look like. They're going to be open, they're going to be inclusive, they're going to provide resources, they're not going to be judgmental, they'll be aware of stigma and trying to work through that. And we agree that these are some of the things, and we'll talk about these are excellent. I'm going to keep this open. You can keep adding ideas if you want, but we will come back and have you answer a couple more questions. So don't close your browser. We will be right back to you. So some of the standard definitions, so thinking about, what you all said about recovery and then what we read in the literature about recovery, the definition we really center on is the one on the bottom. It's here in green, and it says, recovery for us is the experience through which individuals, families, and communities impacted by alcohol and other drug problems use resources to voluntarily solve these problems, to heal wounds, to actively manage their problems, and develop a healthy, productive, and meaningful life. I will say that many of your definitions were just as good as this definition, so that is great. But this is sort of our centering moment. This is what we're thinking about. So as we're saying, we want to help support recovery in our state and help support recovery in your state. This is what recovery means for us. And we're going to talk about a number of studies that we've done on this continuum of recovery to kind of get Iowa poised to move forward. And one of the first ones that we did that really helps frame it was we just went out and talked with a lot of people. I mean, Shawn and I are computational data scientists, so we do a lot in data science. At the back end, we're going to show you, bots that we've created and how we scrape the websites and the things that we do and that we pull it together. And that's all true. But as our grounding place, what we did was we went out and we talked with 43 people, and we did 1.5-hour long interviews and talked to them about their history of substance use and what that looked like and what their needs were. And we really tried to focus on this multi-generational approach to see, what substance use looked like embedded in families and what that meant over generations for the parents you were raised by and the children that you have. And our goal here was to take a not about us, without us framework. So as we're working with the state to think about programming and interventions, we want to really think what voices at the table do we need? Well, we need family voices, and we need individual voices, and we need lived stories and lived experiences to be part of this. So one of the first things we did is we started chatting, and I'm going to share some of the ideas that came out that told us that recovery is really a critical need here. And some of these won't be surprising, but one of the things that we learned is, while recovery is a lifelong venture and people need recovery at all different time points, recovery right after treatment is also a really critical period. So Maria said, and I will say in several of these, I'm going to use the actual words that people said. So some of the language might be different. There'll be swear words, there'll be things like that. But these are the real voices of the people we talked with. So Maria said, it seems like things got worse when I got out of treatment. Things got worse than before I was in treatment, or even in treatment. Things got worse right after. And maybe that's the hardest part about relapse. It's just not, it's so intensive in treatment. And then you just kind of get booted out, like put out in the cold, and it's really fucking hard. It's really hard. Again, this idea of this transition out of treatment, where do you go? Amy gave us a similar idea, and she said, you're in treatment for 3 months and you have no job, no income or anything like that. And when you leave, you can't get a place to live without a job, and you just leave, and then you're like, well, now what? So a lot of my peers have relapsed after leaving because it's a lot to deal with. So that idea of plugging back into the community, many of you mentioned resources. This is what we're hearing from people on the ground as well. Vincent was a little more specific in those resources. And he said, if I wasn't able to get on that program up in this particular city, I don't know what would have happened, because they gave me free bus passes, they helped me get clothes, They just help me do a bunch of stuff to kind of, get a foothold. In my position, some people, when they go through treatment, they have family behind them to help them out. You know what I mean? Maybe give them rides and stuff. I didn't have that. And you know what I mean? I would have no money. Like, you can't ride a bus and go look for a job if you ain't got no money. You know what I mean? Like, sometimes you're in a very bad boat, and some of those programs out there are lifesavers. So connecting people to these programs to help them make that next step, we learned is really crucial for really instigating change. Maria talked to us about that part of the help that you need is transportation. And especially when you're living in a rural or a geographically isolated place, this can be crucial. Maria told us, and that's probably part of the reason why I'm sweating it, because in the last 3 days, I haven't gone to the methadone clinic. I'm trying to see if I can go through withdrawal. And it's been okay. But I know it's kind of a long acting thing. So I don't know when I'm supposed to be feeling withdrawal terribly, but I'm kind of trying to figure it out. It's a real pain in the ass to drive to this. She names the city, it's over an hour away. And she has to drive back and forth an hour there and an hour back every day. To drive there every day, it's a lot. It's gas, it's money, it's time. And it's me just going to the city and then being close to when I can get shit. And it's just too tempting not to. So she gets out of treatment. She moves to a rural place to live with her family and kind of be in a protective environment. But in order for her to get her medically assisted treatment, she has to travel back into the community in which she was a heavy user. So this idea of what transportation needs are and the geographic isolation are really important things to consider as we're thinking about long-term recovery. And then Melissa talked to us about, we also need financial support and job training. And she tells us, I need help with my finances. I mean, I sucked at money and my mom tried to help me. A couple of times I spent too much money because I was an emotional spender, and she took it personal, like I wasn't following her rules, versus I'm an addict and I'm still learning a new way of life. And she just, your counselor is making way too many excuses for you, and there's more to life than being an addict. But when you're an addict, you don't understand what that is. Everything revolves around you and your next high, your next juice. And so as Melissa goes on and describes that not only does she need these resources, she needs people to understand where she's coming from emotionally and psychologically, and also physically, that she has these real addictions that are driving her. And so in her time point, she needed more than just financial training. She needed targeted recovery supported financial training. And so as we're thinking about, what are these steps? How do we take what people need and want and what they're telling us is really going on? And how do we transform that into an action? So this is kind of the fun part of what we get to talk about for most of the rest of our time today. So what we've settled on in Iowa is building a recovery community center network. And on the right hand of the screen, what you can see, these are all recovery community centers, which are the stars, and recovery community organizations, which are like the umbrella organizations for the centers, or the dots. And you can see that they're spread throughout the US. And in fact, only 5 states don't have one, and Iowa is one of them. Utah has one, but it doesn't have a very dense network like you see in some of the other places. And sort of the background on these recovery community centers is the ethic is they're mini paths to recovery, all are welcome. They're one-stop community-based substance use recovery hubs. You go in there to get connected to resources. They're staffed and run by people in recovery. They're volunteer and peer-led. They facilitate a lot of services. And they really came out, you can see here in the urban Northeast, and they're moving across the US. They've largely remained urban, and we're looking for opportunities to move these into more rural places. Shawn's going to come back and talk about some research that we did interviewing the folks that run these across the US to kind of give us a better idea. But before we do, I want to think about the centers themselves. So these are centers that are placed in communities that provide those resources that kind of help us think about this is a recovery ready community. So a group of researchers went in and they interviewed 30 of these recovery community centers and the folks that go to them, and they said, what are the services that you provide? And here is a big list. It's probably too much to read. I'll just highlight some of them. These are things like basic needs assistance, childcare services, Narcan training, recovery coaching, housing assistance, legal assistance, mental health support groups, mutual help groups, these sort of things. So these are the kind of services they do. Mary Jo just posted in Slack Actually, Utah has 5 recovery centers, so that's wonderful. That wasn't on the list when we first got this list. So great that you have them, and maybe this can be something that you can still grow, but these are the sort of resources that you might add to it. So as we're thinking about what resources would be the most helpful and used by people in recovery, that gets us to our next little time to share your voice. So if you go back to the Mentimeter, we are going to go to the next question, what are the most used recovery services? Now we know what are the most used recovery services on the East Coast. We're going to share those with you in a minute, but I want an idea of this Intermountain group, and particularly here in Utah, what are the most used recovery services that you imagine people would want to use? Now, when you're on Mentimeter this time, you're going to have a chance to select the options as they go through. So you'll hit the first one, and it will list them, and you'll choose it, and then you'll hit the second one, and you'll keep choosing it until you hit all 12. Now, again, this is anonymous, and this is totally up to you. But what do you think are the most used recovery services? In your state, what would the most used recovery services be? And what you're seeing on the screen is as each new person puts in their answers, they get reshuffled and moved to the top. And we'll let these shuffle for a minute. Okay, I'm going to start talking about these. What we've noticed on the last couple is that as each new person entered theirs, it's shifting fewer and fewer things. And so, we are getting a little bit of change. Maybe I'll keep these coming. These are really interesting. Actually, I'll give this one more minute and then we'll move. I'm trying to get it up to the 40 participants. We're at 38 now. So if you are started, put yours in. Oh, we passed it. Okay, now I'll start chatting, but keep putting yours in. We'll share this information back with the facilitators, and so they can share this out, and we can just talk about it. But in terms of the people here, the experts in the room right now, what we're hearing are, what are the most used recovery services? You would anticipate that mental health support would be the #1 most used recovery service in the state. And then basic needs assistance, mutual help groups, family support services, housing, childcare, recovery coaching, medication assisted treatment, recreation and social activities, opportunities to volunteer, Narcan, and then technology, internet. And some of those are shifting around the edges. So keep putting it in. What you're thinking here is really useful, because as you're thinking about what resources to put in, what you think will be used will be one of those drivers. And so again, we're going to share these results back with the group in case anyone is interested in this. Now, I want to go to the next question. It's going to be very similar. It's going to actually look the same except for one word, and that word makes a big difference. So here we said, what are the most used services? And next, we want to say, what are the most helpful services? So in this lane, this is what we'll show you in just a minute is people who actually utilized the services then ranked them by what was the most helpful for them in their recovery process. So we have the most used, and then we have the most helpful. What are those services? What's the difference that makes a difference here? And let's think about what that might look like. And if you think it's exactly the same, that's fine. You'll just fill it out in the exact same way. If you think it's very different, you'll fill it out that way. Okay, this is interesting. So by and large, many of the same things that you thought would be the most used, you think in a pretty similar order will be the most helpful, except where before the most used would be mental health, this time it's basic needs. I would still point out that the opportunity to volunteer, Narcan, and technology were at the bottom in both categories, and the tops look relatively the same too. So that's really helpful in thinking about what you think will be the most useful. Let me show you what other folks thought would be the most useful. And then I'm going to pass it over to Shawn, who is a whiz at doing on-the-fly analysis. But first, the most used and most helpful services. This was, again, these are from people who utilize services from 30 RCCs, particularly in that Northeast area. They thought the mutual help groups were the most used. When they said, which ones did you use? These were the orders. And number two, this is interesting. This came up low in both of the Utah ones, the opportunity to give back to the center. Recreation, social activities, recovering coaches, technology. In terms of helpfulness in usage look quite different. And let me show you what I mean. I'll show you a few of the things that I point out. First, in terms of usage, these top categories of usage that we see here, these tend to all be the things that are used are the things that connect people to other people. Social isolation is a problem. When we interviewed all these folks, we had 3 themes that predict drug use initiation and relapse. It was social isolation, economic vulnerability, and stigma. And these are the same things that are going on and that we're seeing right here. So here, the social isolation is a really crucial one that we want to address. Next, you can see that the harm reduction was important in terms of usage, that people both in Narcan and the medication-assisted treatment. And the point on this last one that I'm showing on the bottom of service usage, childcare was used the least of the services, but it was viewed as the most helpful service that people had. So people that needed childcare, that was the real difference that made a difference. So as you're thinking about developing these resources in your own state, one of the things you want to think about is, what can you plug in to get people there who otherwise might not be there? I'm going to pass the baton over to Shawn, who has given a lot of thought to this sort of thing. And Shawn, do you want to share your screen, or do you want me to stop sharing?
Yeah, we can jump on and share mine.
Okay.
Okay, so thanks for that, Cass. I want to tie this back for just a quick minute to the initial question we asked you was, how do you define recovery? And I just want to point out that one of the strongest themes in your own response is this issue of judgment and acceptance and participation that really aligns with a need that recovery community centers fill in other places. You can see by the service usage, this is a subset here that we've given you of a list of over 20 services that community centers help connect people to. And the preponderance of those, the lion's share of the usage is around community. It's around mutual aid meetings, it's recovery coaches, it's service, it's outreach, it's advocacy, it's general meetings and social activities. That sense of community and that sense of belonging and being welcomed is really, really a fundamental feature. And all of the many services connecting to healthcare, to job support, to childcare. It's not that they're low in service doesn't mean they're unimportant, but that becomes really targeted. Not everyone has a child that needs childcare support, but what we see is pretty much everyone needs community. Everyone needs to feel like they have a home and they have a place, and that's really embedded in your own definition of recovery. So we saw that, and we think these are interesting things that recovery community centers can offer above and beyond the many programs that are and services and resources that are out there. So as we look in Iowa to move recovery forward, to meet some unmet needs and to improve opportunities for people to transition into sustainable recovery, we have this goal that in collaboration with our Department of Public Health, and that's to grow a network of recovery community centers. So one of the steps, a couple steps we've taken along the way is we talk to national experts, people across the country who've already been through the experience of founding a recovery community center, to get their experience and advice. And then we've done something that again aligns with what you defined in recovery, which is resources. We have been doing an intensive environmental scan to document all the recovery resources in our state, to know where there is a wealth of resources and where there are deserts or deficits of resources, to know where we should target our efforts. We use that to develop a measure of recovery readiness, community level. Then we built a recovery ready startup toolkit. And then we're also building a website and some online tools to help people find those resources. As was mentioned in the definitions of recovery, finding recovery resources is not an easy thing. So we're trying to find ways to make it easier to connect people to the resources they need when they need them. You've seen this map before. This is getting a little outdated now. This is a little over a year ago, but this broadly shows where the recovery community centers are throughout the country. And we interviewed just under 30 leaders of recovery community centers and organizations. And the map on the right shows where we interviewed from, so all across the country. And we asked them all kinds of questions about their founding experience, their funding model, how they got started, what obstacles they faced, how they engaged with the community and dispelled concerns, how they funded themselves. And they gave us a bunch of advice. And as we collated those responses, it broadly kind of reduced down to 8 broad things. And we'll just pause here for a minute and I'll just kind of talk you through these, because I think these are really actionable and useful for you as you think about maybe recovery community centers where you're in your community, where you're working. So the first is over and over again, we heard this theme that we've heard here today, and you'll hear throughout the next couple of days of this conference, is critical to recovery is supporting many pathways. In your definition, some of you had sobriety and abstinence as a definition, and that's okay. And for others, it's more of a harm reduction and minimizing harm, whether that or not that includes abstinence. And a healthy, vibrant, successful recovery community center supports those different kinds of recovery models, because everyone has a little bit different pathway. We even got the quote here that says, recovery should be like a buffet. Everything should be available in the proportions that an individual wants. And we find that even within a single community, recovery community center, those differences of understanding of what recovery is, they can coexist really kind of quite nicely. It's a nice, refreshing model to some of the divisions that we see in other places in society these days. But another theme was that we should create allies and not competitors. Sometimes when community centers try and get up and running, there's this sense by the treatment centers or by other nonprofits or even state agencies that these recovery community centers are going to compete for resources. And that's not the case. That the recovery community centers, they are an ally. They're there as brokers. They don't necessarily offer services. They help connect people to them. So they're going to get the message out. If you're a 12-step program, they're going to help people find you. If you offer employment services and training, they're going to help people find you. It's a resource to connect people, information brokers and recovery service brokers. And this great quote was, we don't compete as an RCC. We should be a center, kind of like Switzerland. We have to be a place the community can come together. The other is marketing recovery. You really have to get the story out there. This is important for kind of mitigating stigma and changing the narrative is to say, recovery community centers is an important part of a community as the local chamber of commerce or any other nonprofit operating in a state. It's targeted to a specific set of interests, but it broadly helps the whole community. So as you think about recovery community centers in your local neighborhood or community, getting that out there and saying, you know, this is a real positive. It's gonna help people in recovery live in your community, and this is a way to bring them together and to provide supports and services to help them sustain a recovery. And another one was this curbing certifications. There's this broad trend to want to professionalize and ramp up the barrier to get in. And we heard over and over again, just resist that urge. Make it easy for people to get into recovery. Keep the certifications low. There are various standards for recovery coaching and peer support specialists, and those are great. But don't over certify, especially at the beginning. Keep the bar to entry low, and you'll get a lot more people in and a lot more early uptake and buy-in. Another theme was using the recovery language. Stigma is embedded in language, and how we think and talk about recovery matters. Be thoughtful and careful, be sensitive to the local context. Culture varies. Culture in Southeastern Utah is very different than in the urban Salt Lake area, different still than Northern Utah. Places vary and culture varies by place, and using kind of local context specific language, it helps to be inclusive. And then a broad theme is moving at the speed of trust. That, you know, there's all these things you want to do, but taking your time, getting a plan, and knowing that just like recovery is a process, building a recovery community center is a process. You don't have to get there overnight. You can get there over time in a sustainable way. Building a solid foundation makes all the difference in the long run. And then a last couple, one is just paying your recovery staff. While the model is voluntaristic, that's really, really critical and valuable. Having a core paid staff, it goes a long way to stabilize the institution, to have some kind of accountability and some expectations that just aren't necessarily practical with a fully volunteer staff. And then finally, promoting a holistic funding model. It's a lot of varieties of funding, a lot of creativity out there, whether writing grants, going after state block grants, donations, fundraisers, just a whole variety. And most of the successful RCCs deploy a range of funding to support their activities. But that doesn't mean that this is a resource intensive. Many RCCs operate on shoestring budgets, and you can in your community as well. So those are the things we heard from community leaders. And based on that, that helped us to focus on what kinds of resources we wanted to look at for Iowa. So what we did is we've done an inventory based on what we've heard from people with lived experience, what we've heard from recovery community leaders, what we know from the scientific literature, that there are some resources really, really critical to recovery. And for example, hospitals and clinics, really important. Treatment centers, depending on what stage of recovery you're in, on the early side of recovery, or if there's some issues of relapse remission. Mental and behavioral health clinics, medically assisted treatment sites, drug drop-offs, and then things that are a little farther from the formal care. Things like, we know that access to nature really improves people's mental and spiritual well-being. So how many parks a community has? Does it have libraries? Are there a wealth of churches and other nonprofits that speak to people's meaning in life and their spiritual well-being? So we looked at a range of resources that exist in communities already that really support recovery. And from that, we were able to then do something like this, which is we were able to map the resources in our state here in Iowa. And this lets us see where we have a high concentration of recovery-friendly resources and some places where, let's say, some deserts of resources. That's a very helpful stage. And this is a map of all of the resources, and we could do maps to say where are all the recovery coaches and where are the mental and behavioral health clinics. And that helps us to target and funnel people to the right places as they think about where, if they're moving to sustain a recovery process. From those data, then the next step we did is we created an index. We wanted to know which of those communities that are out there are the most ready to start up a recovery community center. So we took all these data and we created 4 kind of numbers, if you will, and I'll talk you through these, and it tells you what our definition of a recovery ready community is. You gave us yours, and here's what ours was. Ours was, as we said, a community that has a large number of resources, the breadth of resources, and then in terms of diversity, and then the depth in terms of the total numbers. That's important. And then the recovery culture matters too. So the size and strength of the recovery culture. So for breadth of resources, we just counted up the number of these 17 resources we looked at. We counted up the total number that they had. So if they had any churches or any childcare, they got 2 points, 1 for churches and 1 for childcare. And then we could score each community on a score of 1 to 17. And then we also measured the depth. So having 3 churches and 8 childcare centers, well, that's 11 total resources. So that's the depth of them. Having many of each resource also is kind of important. But that favors large communities. So we want to look at something that kind of is a little less biased against small and rural places. So we looked at the size and strength of the recovery culture. And for that, based on people we talked to, especially recovery community leaders, we looked at mutual aid and support meetings, AA, SMART, CRUSH, lots of different varieties of support communities out there. And we looked at the total number of meetings in each community. And then we adjusted that on strength by the size of the population. So a big city like Salt Lake should have a lot of meetings. And a small community like Monticello down in Southeast Utah is probably going to have fewer. But relative to the number of people that live there, a place that has a lot of meetings, that has a very strong, vibrant recovery culture, even if it's small relative to a large place like Provo or Salt Lake. So with that, we were able to then map and rank cities in Iowa. And here I show you the top 30. So these are the top 30 communities that we've been working with. They have lots of resources in variety and in total numbers, and they have a lot of mutual aid and support meetings, and also relative to the size of their population, a vibrant community. And we think these are communities that are fairly ready for a recovery community center, and we're working with them. So that's what we've done to find communities. But as you mentioned in some of your definitions here, resources is really critical for recovery. And we're thinking about how do we get these resources to the people that need them? They're all over the place. It's actually it's a real challenge. It's a labyrinth to try and find the resources you need. Do you do the right keyword search? Do you know the right people? Do you know what the meeting is? Do you have to know the name of the meeting to go out and find it to provide support? Do you know that there's childcare services or credits out there for you? And if so, what do you have to do to get them? So this myriad of resources that people need to support their recovery, it's a labyrinth. So we're looking for ways to collect all of those resources together and to put them into some kinds of formats and tools to make it easy for people to find and use them. When you need a support group, typically need it now. We want to make it easy to find those. So I'll show you a couple of things that we're working on in Iowa to make it easier for people to find those resources. So we mentioned that, you bet, Cass.
Oh, sorry. Will you go back one? I just want to add something right here. I put a note in Slack that Shawn mentioned that we did this population weighting, and we really tried to think about population size. And that was because, like many of you, we're concerned about place-based equity and making sure that we really address the needs of small and rural places and geographically isolated places, as well as our larger cities. So this approach that we've taken is something that really tries to consider that and make sure that we're keeping that in mind as we go. So what you see here, and one piece of background that I think we didn't share was that the Department of Public Health put out a call and said, we have funding and we want to build recovery community centers. And no one that was eligible applied for the funding. And so this step, that what we've been going through, so this was a puzzling problem. Like, how do we actually reach out to communities and help build their capacity so they'll want to get funding, so they'll want to start these? And so this has been a rather long journey. You know, at first it was communities come to us, and the communities didn't come. And so identifying these places where there might be hotspots for really quick ability to like ramp up and start these is where we were going in our state. Okay, sorry, Shawn, back to you.
Thanks, Cass. So thinking about how to make it easy for people in recovery to find the resources, one of these really important ones, both in terms of usage among recovery community centers and in terms of talking to people with lived experiences, is support groups broadly. So looking at how to help people find these mutual aid and support groups. One of the things we've done is we've written some programs that go out every morning at 3 in the morning, and they collect data from Alcoholics Anonymous, Narcotics Anonymous, Smart Recovery, and more than a dozen recovery support groups that operate in Iowa. Every morning at 3 in the morning, goes out, collects all that data, cleans it, tidies it, puts it into a single data set, and then we're building a tool that I'm showing you now that puts in a single place where people can go and find the meeting they need. So do you need help finding a meeting? And then what type of meeting you're looking for? And there's a whole list of all those available, including these ones here. And then we ask, where are you at? find a meeting near you. And you can use your current location or enter if you're going on a weekend away and need to find a meeting when you go to visit family in a community you're not familiar with. Help you find that one as well. And then times matter. You've got kids, you got work, you got all the things that happen with life. Finding a meeting that works for you. And then we project that to them. We show them where those meetings are near them in map form and in list form with links to how they can get there in contact, and whether that's a virtual or a place-based. So these are the resources that we give them. And within any one meeting, there's some specificity. Some people feel comfortable in large diverse groups, and others really feel comfortable only people that are very similar to them in the ways that they define. So we do things like this. We help people have children, maybe to find a meeting where childcare is offered or where children are welcome. Or if you're someone who's an ally or a family member and support a meeting that you can attend as well. So a range of kinds of meetings and helping people to find those as well. And then lastly, we do this in a way that makes it mobile friendly. Not everyone has a computer and not everyone has the same kind of resources. So doing this in a way that someone on a phone can find a meeting near them. And we're doing this not just with meetings, but with a great many of the recovery resources. And the goal is to make it easy for people to find the resources they need to support their own personal recovery journey. So in terms of what we're doing in our next steps, I showed you that map of 30 kind of high value recovery ready communities. We're collaborating with a small number of those to set up some recovery community centers to bring those resources together, to connect the recovery community that's in those places with each other and with a supportive and welcoming larger community. We're also doing something similar at the collegiate level. What we find is that this transition from young adulthood or adolescence to young adulthood to early adulthood is a real risky time period. And as people go, leave home, go to school and start those transitions, it's a very high risk time. And there's a recovery community center model that's designed just for colleges, whether it's community colleges, state schools, universities, and private. It's a collegiate recovery community center. And it's a very, very successful one. I'm working to make sure we get those on every campus in our state. So we have the ideally community recovery centers in many communities throughout the state and on many campuses throughout the state to kind of get the resources that people need at the stage of life and the journey they're on. And then finally, we're trying to put many of these resources together in an Iowa-specific website, a Recovery Iowa website. And for our state, that's kind of proxies as a recovery community organization. It's a clearinghouse for all those resources and all that information about recovery that's custom to our state. Yeah, I'll pause there and say, Cass, I'll let you.
Yeah, so now we just wanted to open it up to you all. We actually purposely took, we both love to talk and there's a lot to talk about, but you're the experts here. So what advice do you have for us? What did we miss? What did we get right? What do you want to do that we could help you think about? This is really just a time to chat. So consider this like open mic time where we'd really love to hear from you. And we are fine in both ways. Like, what are we missing? What are our blind spots? What's working well? And then again, back to this, or do you just want to talk about how it applies to you? And can we give you any advice? We're here to help.
Thank you so much for sharing your expertise. That was incredible. And I encourage people to raise your hand, use the Q&A box, or just type your questions in the chat. And while we're waiting on that, Claire, if you have some housekeeping things you'd like to go over.
We have one more presentation this morning and then we'll chat about our lunchtime and afternoons after that. But if anyone's having problems with the Zoom or has questions about that, feel free to put it in the chat as well.
Yeah, we just can't have the last thing that I say, we're here to help. There's a joke when we've been working with all of our state colleagues. at different agencies. And they say the last thing you want to hear from an academic is, hey, don't worry, we're here to help. That always means there's a problem. So can't have that be it.
A good question here of how to connect with the prevention coalitions. Every state's really quite different, and even at the county level, at the community level, organizations there's a lot of variety. So I would say there's not a one size fits all here, but we have a number of organizations in our state that are very active on prevention, and one of the things that we do a fair amount in our state is we have various kinds of diverse boards where we try and put people in prevention and treatment and recovery together, whether they're in the formal care or on the community side or people lived experience. So try to put these kind of diverse groups together that maybe don't always talk, to share information and share resources, and those handoffs that Cass talked about. The handoffs as we go from treatment to recovery is a really critical one. And on the front end of kind of managing prevention to minimize the amount of treatment that's needed. So those handoffs are really critical in keeping people talking.
I will add, in our state code, we have a direct focus on prevention and treatment, but it is not written, recovery is not written into our code. And so that's one of the reasons that this is kind of coming on slowly and right now, is that there's funding available and there's ideas available, but this is the last of that three-legged stool that we're moving forward, because there's been a lot of effort and even legislation around the first two, but not this third one. In Q&A, Carol asked, have we done any work in process disordered addictions, pornography, video games, gambling? Gambling is actually part of the same unit that does the substance use in our state. And so in the website and the other materials, we do have links to that, but we have been honed in really close on this recovery side, mostly because it's just such a big gap, and they're trying to fill the gap with as much information as we can pull in right now on that area.
Matt asks about court order clients facing additional barriers. This is a real challenge that you go through the hardship of detox, of getting treatment, and then making that kind of mental transition, trying to envision a life in recovery. And at that moment when you're really kind of ready to make that transition and you're willing, the ability is really stymied by some of those kinds of court level institutional challenges. We hear over and over again, court fees, lost driver's license, unpaid parking tickets, that backlog of kind of especially financial hardships that accrue during a period of intensive and harmful addiction. It really makes that fresh start and that move to recovery challenging. It's not just financially, but especially psychologically. The motivation, and we heard this word from you on recovery, hope, that hope that it can move forward. So we're working in our state to look to opportunities to minimize those barriers, to help find ways to get those fees and those fines and that backlog cleared out. So when people transition from treatment to recovery, they really do get this sense of a fresh start, that they can see a bright tomorrow and sustain that recovery.
Thanks, Shawn. I want to add a little bit. So Matt, on your question about if they go through court order, does that mean they have a more difficult time accessing? And I think there are 2 points that are interesting on that, as well as what Shawn said, which was, he always gives these like beautiful answers. So I'll give you the more like data answer here. But one is, what we see is that actually the number of court-appointed people who are going into treatment is going down, and the number of people who self-initiate into treatment is going up. So in terms of prevalence, that's actually changing, which is interesting. The second is, even when we talk to individuals, that connection is not always there. So one of the first stories I gave was Vincent, he was the one who said, I needed bus passes and I needed clothing so I could go do interviews, and those resources really helped. Well, Vincent almost purposely, and we've heard this from more than just Vincent, this is not just a one-off. We hear from a number of people who purposely kind of put themselves in a position where they're going to get caught because they know they need help. And so he talked about going into jail was really helpful as sort of a recovery strategy. It was like his treatment, and he had to get sober. We hear that. We hear, we've interviewed many women who purposely got pregnant to try and force them to get off of whatever, like particularly meth. So these things about, the things that we might think feel more like forced, sometimes people are opting into those, which is really interesting. More to discover there, but that is definitely something we're seeing in the people we talk with.
So
Shawn, it looks like you have an idea. Yeah.
two more questions. There's one about a harm reduction and whether we have them in our area. We do have, ours is the Iowa Harm Reduction Coalition, and it's in a couple of our major population centers. We work closely with them, and that's a newer model in Iowa. I will say in Iowa, we are in the classic sense of traditional state. The 12-step framework is very, very dominant. And the harm reduction paradigm is still relatively new. It's spreading and it's meeting some unmet need, which is really, really important, and especially in our larger urban centers. And then there was a second question about what is the meaning of paid recovery staff? So in a recovery community center, I mentioned that these are voluntaristic. These are peer support led and voluntaristic. That's true for like 98% of what a recovery community center is. But a paid staff typically means you have like an office manager or a recovery community center director or CEO, depending on how it's incorporated. And in the most successful models, there's usually at least one paid staff that writes the checks and pays the bills, keeps the lights on, pays the rent, locks up, opens up. And in a larger, more established, there may be 2 or 3 or even 4 staff that help to kind of coordinate if they have the right resources. But typically at least 1 or 2 people that kind of hold things together, and they're on payroll either through grants or contracts or donor support, things like that.
So what we heard from folks was sometimes they just see this huge community need and their heart is in it and they just start and they're doing it for free. But the advice we got over and over is honor the people with lived experience and pay them for the work that they do. Don't just expect everyone to volunteer. And so that was why that was one of those issues that it came up that like people are willing and they start, but for sustainability, it's important to have income coming in that can pay them. And also it's just important that you're not, the people that tend to volunteer are people with lived experience, and we don't want to keep these groups in poverty, right? Like it's important to pay them and make it sustainable for individuals as well.
That broad theme, it aligns with this advice we got about not over professionalizing. It's kind of a, it almost seems contradictory, but these do align well. And that is you saw that in terms of usage of recovery center resources, that voluntarism and giving back is very high. It's just really, really important. And it's prevalent in recovery community centers. And it's also prevalent among people who have a history of substance use. There is an overwhelming desire to make amends, to make it right with family and friends or an employer that they may have stolen from or dropped the ball on and gotten fired. People want to make things right. They want to give back. And that first step of giving back for many is those entry into a very unprofessionalized formal position. And if that first step requires many, many hours and lots of resources, paid resources for training, it's a real barrier. So you're looking to find ways to allow people to give back to where they want to serve, where they maybe feel some need to make amends, to make that easy and to make that rewarding, but ultimately transition and progress people to a paid environment.
I just want to point out, I meant to point this out earlier, and I think it's really important is, look, these are folks who actually use the services. That one of the most used services was the opportunity to volunteer. And in helpfulness, the second most helpful service was that opportunity to volunteer. So this idea of getting people to engage and having people with lived experience being part of the process is really good and helpful, and we're not trying to deter that. But what we have heard regularly was this curb certifications and make sure that you value people by actually paying people for work that they do.
100% agree. Thank you so much. We have learned so much from you today. We really appreciate you joining us. Everyone has your emails now, so you can expect us to all flood you with questions. Thank you. We'll be moving on to our next panel in just a moment here.
Thank you.
Thank you all.
Hi, Chris. And Miss Dutson and Keady and Miss Hatch. Dr. Prest. Did I pronounce your name correctly? Dr.
Yes.
Prest?
Yep. It's almost too simple. It fools people every time.
I know. That's what I was beginning to wonder. Good morning, panel. This is going to be exciting. Everybody's here.
Okay.
Is Susie alone?
So we are now proud to present a few of our colleagues who work with substance and opioid use disorder every day. Our rural prevention, treatment, and recovery panel features Heidi Dutson of the Utah Department of Substance Abuse and Mental Health, Robin Hatch of Northeastern Counseling Center, and Dr. Lauren Prest of Moab Regional Hospital. This panel is moderated by Cris Meier and Tim Keady from Utah State University. I'm just going to read your bios real quick to give an introduction. So Heidi Peterson Dutson has worked in the prevention field for 12 years. Heidi is currently a prevention administrator and regional director, providing technical assistance for prevention programs and coalitions across the state of Utah to help ensure best practices and fidelity to evidence-based frameworks. Heidi worked previously as the Communities That Care coordinator for Tooele City and worked to implement evidence-based programs in schools and for families. Heidi helps to advise the underage drinking prevention work group, the interfaith prevention work group for suicide, and the state epidemiological outcomes work group. Welcome, Heidi. And then we have Robin Hatch, who has served as the prevention coordinator with Northeastern Counseling, covering the Northeastern district for over 17 years. He has been a prevention champion and has worked hard to reduce substance use and suicide by addressing stigma and promoting collaborative partnerships. During her professional career, Robin has been awarded the 2014 Excellence Through Community Action Award, the 2015 Merlin F. Good Prevention Award, and the 2019 Duchesne County School District Extra Degree Award. And most recently in 2019, the Governor's Award. Wow, well, congratulations. And then last but not least, we have Dr. Lauren Prest. She's an addiction psychiatrist who currently works for Moab Regional Hospital in Moab, Utah. She received her general psychiatry residency training at the University of Utah and is fellowship trained in addiction psychiatry. She currently runs the mental health and addiction treatment services at MRH. She has significant experience developing mental health programming in resource limited areas and for marginalized populations. We're so happy to have all of you here today. And I am going to turn it over to our moderators, Tim and Cris.
Okay, very good. Well, we're excited to be here with you today. Cris Meier is joining me. She's going to be watching over the questions if I don't catch them as they go and comments. We'll kind of do those as we go through this process today. But we want to begin with kind of the summit theme question. The theme of the summit is bridging harm reduction and recovery in rural communities. Sometimes there's tension between recovery services that focus on abstinence from drugs and harm reduction services for people who currently use drugs, like syringe distribution programs. So I'm going to ask our panelists, what does harm reduction mean to you, and how do you use harm reduction principles in your work. We'll start with Ms. Dutson, go to Ms. Hatch, and then Dr. Prest.
Great, thank you, Tim, and hello, everybody. It's an honor to be with you today and to discuss this, and grateful for the chance to look at harm reductions in specific relation to rural communities. I think it's a super important focus and look forward to many of the things we'll be talking about today. I'm a prevention girl, and you heard my bio. I'm really passionate about prevention. And so I'm going to take just a little different angle on harm reduction. And that really is what prevention is all about. And often if you talk to a preventionist, you'll hear us talk about moving upstream. And we recognize that in all parts of the continuum, every part is important and needful. We know that it's important that we have crisis intervention, that we have the best of treatment facilities and professionals to help people that are addicted. And on the other end of the spectrum, we're grateful to be working with science that has evolved over 4 decades, 40 years worth of science that has informed us of things that we can look for in our communities, in our families, in our schools, that we refer to as risk factors, and then also protective factors. And we know that as we reduce the risk factors that we find and enhance or increase some of those protections, that we can actually eliminate, prevent the onset of any use of substances at all. And so in prevention, that is our ultimate goal, is to reduce that risk, increase that protection for communities, for families, for individuals, and within the schools. So appreciate being able to share with you today.
Thank you.
Okay, I think it's me next. So one of the things that at harm reduction, I think prevention looks at harm reduction a little differently, as like Heidi was saying. So when I think of harms reduction, I think of reducing the harm to the entire family. We know that those that are going through recovery and that are still suffering from addiction, that some of the things that have happened in the home may have put the entire family at a future increased risk. So one of the things that I look at harm reduction, and I've been looking at some of the research on this, is for those that are in recovery, if we can start pushing our parenting classes at the same time that they're actually working through their own recovery. All of a sudden you've got a family member whose priorities may have been seeking substance use or getting high, and now that they're in recovery, well, at least in my experience, that those that are first in recovery are so excited about their new life, their new opportunities, that they're very, very energetic about helping others. So making sure that they have the right skills to help their own family. And now that they're engaging in their family more instead of the drug seeking or the drug using, to make sure that they have the skills to parent properly. The whole family dynamics is going to change when somebody's in recovery. You may have some teenagers that have been doing whatever they want because the parent has been disengaged, and now they're super engaged. So let's just make sure that the parents have the right skills, and that the family goes through this process together.
Thank you.
Hi, everybody. Thanks again for having us. I think, I'm more of a treatment person. I'm definitely not a prevention expert, but I would say that this is where treatment and prevention can kind of go hand in hand. Is in my world, I'm treating a lot of individuals and a little bit less the family system. So this is where I really love collaboration and working with, non-medical people in particular, because there's so many skills that the family system needs, that the individual needs, that ties into that prevention piece. And particularly when you look at, like the kids in the family system. I mean, we're talking about trying to interrupt those intergenerational patterns, but perhaps for the adult that I'm treating, for example, or the parent, the substance use is already there. The substance use disorder is already established. So harm reduction means that, by engaging in perhaps like medication use, we don't ever say that there are no harms, no side effects to medications. There's always the potential for that. But is the risk lower that they will have further harms associated with, injecting heroin when they can, be involved in a medical system instead? Absolutely. Or if we're helping them and get engaged in a syringe program. I mean, we're not often asking people to flip a 180 and be completely substance free. In most situations, that is completely unrealistic. So we're looking at how do we help them, not completely change the behavior itself, to a kind of the standard of complete abstinence, which for most people is unattainable, but that we can prevent them from getting hepatitis C or HIV, and then not also having this terrible chronic medical problem in addition to their substance use disorder. And now they're more present for their children and they're going to live this long life. And we can continue to work with them and keep them engaged in services. So I think, we want to use all of these strategies together at once, which is the beauty of collaboration. But it's also, I think what harm reduction really looks like in practicality.
Thank you all. I appreciate those comments. I know for the patients that I work with that are in recovery, when we talk about harm reduction, many of them don't really understand what we're talking about initially, but as you start explaining it to them, they look at, oh my goodness, you're right. This is what I'm trying to do. I'm trying to be more active in my community. I want to know more about my family. I want to know more information about what's happened to me and what I can do to be better at, we want to call, and we talk about using correct language, but many of my patients we work with want to heal. They want to be healing themselves as well as their family members and other loved ones. So I appreciate your comments. And we've talked a little bit about this when the question was, how do we think harm reduction and recovery can work together to help people in rural communities? We've talked a little bit about that now, but maybe if you guys could just talk a little more in depth about what's going on in the rural communities between harm reduction and recovery. Maybe just give just a brief response to that question. And we'll start with Dr. Prest, and then Ms. Dutson, and then Ms. Hatch this time.
So in Moab, we have, we don't have like a specific harm reduction coalition, for example. I think there's, a lot of bigger areas do have those. We don't. But what I would say is what we're attempting to do is try and allow harm reduction ideals to permeate a lot of our agencies. And I think we are building a coalition now just generally around substance use disorders, where multiple people from different organizations whose clients that they're serving are all getting touched by a substance use disorder. And, through that level of sort of more general collaboration and planning and education and those pieces, I guess we'll probably get into this in a lot more detail too, but I think in our community, being small and having to utilize and optimize every resource you have, it's really vital that we all work together and that we all try and, we're not just focus on educating, people who aren't already part of this sort of problem-solving network, but talking to each other and educating each other and looking where we can crisscross our efforts. And harm reduction, I think, is a huge part of that, because harm reduction requires, I think, a lot of buy-in on a cultural level. And if we're not united around it, I think you can't be quite as successful.
Thank you. Ms. Dutson.
Dr. Prest hit on so many key things there that I really appreciate. And she mentioned coalitions, and in prevention, we really, really value the power of a coalition for the very reasons that she talked about, coming together around these different community efforts, really looking at the science and really understanding the data. I think in terms of harm reduction and how that is defined, often there can be a lot of different perceptions about that, whether it's enabling drug use or actually preventing drug use. And so to have a coalition where members can come around and really understand the data and the science behind it and really understand the outcomes can be a powerful collaborative tool. So we encourage people to seek out collaborative coalition opportunities. And I love that some areas have some specific to harm reduction. I know a lot of areas, at least in our 13 local substance identified area, we have 13 in the state, there are at least one coalition in all of those areas, and in several of those areas we have 5 or more coalitions. So I encourage everybody to seek out those local coalitions, and in this collaborative spirit of really meeting people where they are at. I love that was mentioned in the comments by Savannah. I think meeting people where they're at, but looking towards the science and the data and using that to steer our efforts. Everybody comes to the work that they do with a different passion. We all know people that have been affected and have suffered a lot of this human cost. And so it's really important that we look at the data, we look at the science to guide us. And as we do that, that can be the thing that keeps us going in the right direction and be that common ground that we all can look to.
So I'll just expand a little more at the coalition level. So our area has the Prevention Advisory Coalition, and part of that coalition, we do have the opioid subcommittee. So during that subcommittee, we do things like we're planning the take back events, attempting to get the unused medications out of the home so that they're not available for people to misuse. Our committee also fights the stigma to getting help. So when people are ready to go into recovery, they know how to access these services, how to access the recovery groups. And then we've also have worked with the needle exchange. They are happening in our area, but one of the things, we talked about stigma and the resistance to some of these harms reduction. We need to make sure that they're entering our community in ways where it's not going to increase the walls around that and the resistance to that. Making sure that they're not distributed in parks where the children are. Let's be smart about where we're doing this, not to increase the resistance to harm reduction in our communities. So, and then I think that needs to be done at the community level. I don't think somebody outside of your community is going to know the best ways to do these types of things. And that's where the coalition, it's the ground, our feet are hitting the pavement. They're doing the frontline work there.
Yes, thank you all again. I know that in our communities, for example, that I work with, it is the people that live there that make the difference, whether it's in a coalition, whether it's people that are doing the services, whatever might be happening. Also, the people who are in prevention. We do a lot of great work. Sometimes people don't know what's exactly happening in their community, but by going online and looking for some coalitions, they can get some of those answers, especially in some of the tribal and rural communities that we're going to talk about in a moment too. We need to do some more work, and we're working on those things, but maybe all of you could just comment on some of the work we're doing in some of the tribal areas, and some prevention efforts that are going on there. And if anybody wants to take that first, you're welcome to do that.
I'll go ahead if the other two aren't. I know in several areas within our state, people are working with the tribes, and I'll just say, since she's on this panel, and not just because of that, I would say it even if she wasn't on this panel, but Robin's doing an excellent job of working with the local tribes in her area. So in terms of what that takes, I'd just like to point out that, really having trusted relationships is so important. That's kind of one of those intrinsic qualities. And I know last time I spoke, I talked a lot about the data. Looking at your local data can be a super vulnerable thing to do. And sometimes it isn't fun to look at, and sometimes it requires that we look at things that aren't really pleasant about our own communities. And I'll look to my own community for this example. I live and work in Tooele County. And when we first started gathering some of the data through our SHARP survey that we do, our alcohol rates were among some of the highest in the state. Our teenage pregnancy rates were among some of the highest in the state. But as we had leadership that was willing to look at that, kind of square in the eye, and kind of have that willingness to be vulnerable about it and to share that with other local community partners, they were able to adopt one of the prevention models that is built on this research that I've talked about. And all of those rates have at least cut in half since they have implemented that model. So I just want to point that out, that it takes this trusting relationship and this idea that we're all in this together, not to compare or to point fingers at communities that you know, maybe rates are higher, because at the end of the day, there's struggle everywhere to some degree, right? But really looking at that data in a trusted way, building on those relationships to again, look at the best tools out there can be a really powerful thing and lead to transformation in our communities.
Thank you. Anyone else want to comment?
I'll just comment that I think when we're working with tribal communities that we need to make sure that we have strong tribal partners. One of my first tribal partners was Michelle Chapuz. I hope she's listening to this. Wonderful tribal partner, helped me gain access to the community, showed me what I was doing wrong, what I was doing right. So I think that's huge. We also have Felicita Fulbear and Zaisha Dashi that actually are members of our Prevention Advisory Coalition. The tribal community is part of our entire community. We need to make sure that the coalition represents our community. So when we're doing our coalitions and the recruitment, make sure that the people on your coalition represent your entire community. And I think that's a huge factor with working with tribal communities.
And we have several comments in the chat box. I just wanted to go back to one question. It wasn't exactly a question, but I'm turning it into that, Savannah. But Savannah mentioned that harm reduction in rural Utah is hard to fund. So I'm wondering if anyone on the panel has any ideas for how to address this barrier in not only rural communities, but all communities.
So I'll speak a little bit to that. I think just going back to the power of coalitions. And, you know, I do work for the state, but I don't work specifically with the harm reduction. So I can't speak to direct funding streams for that. But I do know that as coalitions work together and find a need, they can petition local and state legislators to create that funding. And, you know, we've seen that with remarkable change for all substances when it comes to different policy measures. So those are things that can be advocated for. And again, there's power when we eliminate those silos and work together collaboratively to appeal for those funds.
One of the hardest thing I think it is true is the funding sources. We're told to look at our data, do what our community needs, but then the funding sources has different rules of what they want. I think we're getting better at that as a state. I think it used to be a huge problem years ago. When we start digging into the prevention science, we can find the risk and protective factors for the community that may be able to meet the needs of the outcomes that the community wants. Again, for finding the funding, connect with your local coalitions. We're getting better and better at finding the funding that we need to address the needs that are in our specific communities.
Yeah, I would echo all those things. I think, you know, grant work is another option. Of course, it is very laborious and requires a lot of staff and or training to get, especially in small communities where we don't have a huge skilled workforce. I mean, we often have to then invest in people who can learn how to run those sorts of structures. We're doing that now in Moab, where we're working on a big SAMHSA grant, and one of our big agendas is to use some of those grant funds to actually, train and invest in some of our people who maybe haven't done this work before. I know that not all federal funds in particular are supportive of harm reduction efforts. Like, I know we just recently got permissions to use funding for fentanyl test strips. That's a harm reduction option. I know syringes are still a barrier. Contingency management is still a barrier. There's a lot of pieces that are not great yet, but that may be one of those places that we focus lobbying efforts as well, so we can start to change those tides. Of course, I know we're talking about a lot of time and effort, especially for people who are not being paid to do these things. So I'm certainly never going to sugarcoat it. It's not great, but I think this is where we focus some of our change over time, so that we can see these changes, like, finally being able to buy fentanyl test strips. That's something we didn't have last year, and we have that now.
Very good. Thank you. Thank you all again. One of the things we were going to talk about just briefly was the innovative ways prevention's addressing risk and protective factors in the rural areas. And by talking about the fentanyl test strips, that's a little bit of what we're doing, being involved with the coalitions, some of those things that were going on in rural areas. Are there anything else that you guys wanted to just mention that's going on that you would consider innovative in some of the rural areas?
I think the recent pandemic that we're starting to see the light with has certainly, whether we wanted to or not, has kind of forced us all to think in terms of innovation and alternatives and contingencies. And maybe there's been some silver lining to that, as far as being able to offer some trainings and different things like that virtually online. And of course, with some populations, that only further widens the gap if there isn't access to those kinds of technologies. So one way or another, the pandemic has certainly taught us a lot, and maybe exposed some opportunities as well as some additional barriers. Something I'd like to highlight, again, is something Robin's done in her area, and she can expound on it if she would like. But in terms of reducing risk factors, Robin leaned heavily on a model from the science I referred to called the social development strategy. And she recognized that in her rural community that there was a need among some of the senior citizens, that they were feeling very isolated. We all know elderly that maybe feel like they don't have a purpose, or maybe not as useful as they used to feel or to be. And so Robin partnered with the local foster grandparents and had them all trained in the social development model, and then paired them through this agency with youth in schools that were struggling with their academics, and they became their foster grandparents. And in this, they were doing more than just tutoring them in their academic skills, but actually building relationships with those kids by finding opportunities to teach them skills and then giving them recognition for some of those things. And even through the pandemic, we understand that these foster grandparents were missing these connections with these kids so much that they were actually trying to sneak to these kids' homes so that they could connect with them. And Robin was able to work with us at the state and obtain some iPads for these foster grandparents. And so you can see there, like, it's an innovative, little bit out of the box kind of way to think about prevention. But certainly for a lot of these kids that may have had increased risk for opioid use or alcohol use, they had another layer of protection, another role model. And maybe for some of them, it was their only secure role model that they had. And so anyway, kudos to Robin for that great strategy, and she may have some things to add to that as well.
Well, like Heidi said, we got this up and running and then COVID hit. So we did find a way, we did get them the iPads. We partnered with our local technology college and they actually trained the foster grandparents on how to use the iPads. After we got these iPads, we realized some of the seniors didn't even know how to turn them on. So we had to start and get them trained. Some of the early findings that we're finding is not only are the kids seeing the success and the teachers are reporting success with the kids, we're noticing the outcomes for the seniors. They're not getting as sick. They're not going to the doctor as often. Their opioid consumption themselves for their aches and pains has went down. So it's kind of a win-win-win, saving taxpayers' monies on tutoring the kids, all this help. We have 50 grandparents going in and out of the schools and helping about 500 students in our Tri-County area. So, and again, this population looks like our community, the seniors from our entire community. So it was a huge success, and we do thank Heidi for coming down and helping train those. Like I said, if you can show the need, the state's been pretty responsive if you can find the data to back up the need in our area with some of this extra funding.
Robin, can you repeat the name of the program and where it happened, if you can share that? There was a comment in the chat box about that.
This is the social development strategy that we're working on. It's part of the communities that care. And then our foster grandparents, I'm pretty sure that they're across the state. So a lot of times what these seniors do is they will just go into the schools to assist with reading or helping the kids with math, or maybe a family is going through a divorce and the kid is isolating. So the schools will pair these students up with the foster grandparents. What we have done is we've trained these same foster grandparents in the social development strategy, given them small rewards for the kids to make their efforts complete and more fidelity of the social development strategy. So we are seeing success. The schools love it. We've got all 3 of our school districts that are participating. And again, the foster grandparents are so excited. They just think this is wonderful. And now they can take these iPads home. They have to check them in once a year with the program, but we allow them to take them home. They're communicating with their families. They're outreaching to each other, not just with the phone, but they can actually see each other now, even if they're isolating because of COVID. So again, it's just a win-win.
Thanks, Robin. I just want to share in the chat box, some of the comments are about definitely the importance of peer support in this process, and also, you know, the idea of collaboration in the community to be able to do this like important work. So
Chris, I also just put in the chat a link where folks that would like to get in contact with their local preventionists, they can access that map, and they can update them on how of these similar strategies are being implemented in their own communities, or maybe bring ideas for additional collaboration.
Yeah, one of the things I was just going to mention is that in Box-Elder County, we had a program we were going to try called Strengthening Families program, 10 through 14. We expected to do just a pilot. Iowa State had given us some funding. We also had some funding for Southern Utah. But we were provided funding to use it just in Box-Elder in one school. And we thought we'd get 3 to 8 families signing up. This was during the pandemic. And we had 51 families sign up. And we went, wait a minute, that's not what we expected. But the families wanted to be with somebody. And also it was parents looking for some help with their children. And we worked with 4-H and some other people also to provide more services. But to us, it was really fascinating to see that need out there. And we talk about the program we do with Strengthening Families to try and reduce the incidence of drug use later on in their lives by building that communication between families. So it's really fascinating to see that need. And we're seeing that now even in the chat, and people are talking about some of that. So So I do appreciate those comments, and for Cris giving us that information off the chat. Well, one of the things that we talk about also, we talk about data showing us that we might be successful, but how do we know that your prevention efforts are being successful? We'll start with Dr. Prest and go Ms. Dutson and Ms. Hatch.
Well, again, I'm not a prevention expert, so I'll definitely leave the nitty gritty to Heidi and Robin. But I mean, I'm learning. I'm a student of prevention in my job now, and I would say, it's data driven in a lot of ways. I mean, we do have to collect a lot of information to prove that what we're doing is successful, because otherwise, why do it? And I think we all are guilty of having a lot of presumably great ideas that don't pan out. And so we need to make sure that we are, investing our time and our money and our resources with fidelity. But with that, I'll definitely leave this to the experts.
So I'll go ahead. I think knowing what you're successful depends on your community. Sometimes if you get invited back again, that's success. Especially to a community you've not been engaged in before. We do watch the data. In the time that I've been prevention coordinator here, we've been really pushing the Parents Empowered program, the bonding, the monitoring, and setting appropriate boundaries. And one of the successes that we've had is the underage drinking consumption has been reduced by 62%. And it wasn't overnight, it was little by little, and over those 12 years, it adds up to 62% reduction, and that's huge. So I think success needs to be defined by the community itself. Again, if you've never had prevention efforts and people are starting to ask or inquire about them, that's huge. That's a huge success.
Yeah, I would agree with everything Robin said and Dr. Prest. Certainly we rely on that data. Every program, I love that Tim mentioned strengthening families. Like all of those programs are going to have pre and post survey data where we can assess knowledge and attitudes and how they are changing. But then over time, the question still remains, are the skills that are being learned being then implemented into those families? And those are really going to bear out through longer term data that we can assess in the SHARP survey, for example, and see how some of those risk and protective factors are changing. And I think another thing that I just point out here is that it takes a lot of patience, and that patience can be a very frustrating thing, right? Especially, again, we came around, I'm sure that everybody here that's at this conference today has some reference point of pain as far as how addiction, specifically with opioids, has impacted them either personally or in their communities. And that creates in us this need to want to fix it now. And while there are things that we can always do now to improve it, we have to understand that long-term change, especially throughout our community, does take time, but that there is research available out there for what really works. So that's why we continually point people to that, to have the patience to say, okay, what does the research show me is most effective? And if I'm going to take that passion and do something about this, let's do it together, and let's do it based on the best research that we have so that we can get those ultimate best outcomes that we're seeking.
Thank you all again. We appreciate that. Some of that guidance also. I know that we've had in our communities, in Cache, Box Elder, and then across the state, having opportunities to work with people who are part of coalitions has really been very beneficial. And for me, coming from back east and coming back to the Utah area after many years, it really had changed a lot, and starting to look at the data and see what was going on, and trying to decide where we would start as part of our work became very important. And I appreciate all of you that have done all that work also in your communities. We're going to talk a little bit now about what have you seen that are some gaps in services in Utah's rural and tribal areas. If you can talk a little bit about that. We'll start with Ms. Dutson, Ms. Hatch, and Dr. Prest, if you have some comments.
Yeah, I think some of the gaps that I see, and I think it's kind of been alluded to today, that, this sense of really understanding all areas of the spectrum. Do people in prevention really understand the struggles and the barriers and the research behind harm reduction and what's happening there and the benefit of some of those strategies, and vice versa? So that's always a barrier. I think something else that is important is, are we taking the time to really understand the distinct differences between our rural and tribal populations? Again, I'll go back to that word patience. That takes patience. It takes vulnerability. It takes time to really understand some of those dynamics. But if we're not doing that, we go back to that first principle of we don't want to do harm. And if we're not really careful to understand the populations that we're working with and trying to help, it can result in more harm than good. So I think really taking a step back, being culturally aware, taking the time to do that. And I love that it was stated here in the chat that there's different versions of like the Strengthening Families. And I'm sure if we vetted those two programs out, if you took the English speaking Strengthening Families and tried to plug it exactly as is into a tribal community, that you would not get the same results. So that's a real benefit there when there's programs that have been developed specific for populations there to meet their needs the best.
So again, some of the gaps in services is there aren't a lot of evidence-based programs that have been started in rural or tribal communities. So I think that, so finding the adaptations that are allowed that can work with the community. One of the things that I suggest is to always have, if you're going to attempt to push a program into a tribal community, is to have tribal partners that will absolutely tell you this is not going to work. Don't waste your money and your resources. Our resources are so limited. So let's not waste any of them doing things that are offensive or won't work, or even if they don't do any harm, let's see if we can find something that actually works. Data is hard with tribal communities. So one of the things that I'm working with right now with some tribal partners is, even if they won't share the data with me, to have the data themselves, start tracking things themselves. They don't have to share it. They don't have to give it to anybody, but let's make sure that what we're doing is making a difference. And just the involvement with your entire community. I think that's huge. We don't have the same after school programs that other areas do. We've attempted after school programs in our area, but nobody has the time for 4 hours after they're done to drive everybody home. It's not the same as the kid participating an extra half an hour after school and then walking themselves home. Those types of things don't happen. We have some of our kids that in one of our areas that is spending, on a good day, an hour and a half each day on the bus. And that's on a good day if there's no snow and there's no boat traffic. We're just not the same, and we have to adapt to our rural communities.
Yeah, I would echo all of those things. And I think what I think is also really important that I think is part of what Robin was saying too, is that we have to approach any community that we are not specifically a part of with humility. And I think it's important to note that all of us who are professionals, we are different in some ways than the patients that we are not part of that community anymore in a lot of ways. And there's a power differential that is vital to understand. And you cannot just come up to any patient and assume they're going to be grateful for your help. So you really need to know the community well and get the buy-in as best you can, but talking to a lot of people and recognizing that there's a lot of history there before you ever had some good idea. So you really need to make sure that, you're talking to kind of the people who've been the most devastated by the issue that you're trying to fix, and understand that potentially for generations before you ever arrive, there have been efforts to try and fix it. You're not the brainiac who figured it out, right? So I think we have to have a lot of humility and understand that people have been fighting to fix these issues for a really long time. You're asking for a lot from people when you want to start a program. And there, at least in my community, I mean, I would say there is some apathy, in terms of all of the times things have been attempted to change and then they didn't change. And so, it's hard on people, it's hard on communities to be trying these efforts over and over again. So, try and understand people, and also try and get to know the history too, not just the problem itself.
Yeah, great answers. Great information from some very knowledgeable people. So we appreciate all that you've answered so far. We're going to try and just wrap up a little bit as we start going through some of these final questions. But I know people are asked a little bit about this. We've commented on these a little bit, but what ideas might you have for overcoming some of the barriers, limited resources, available shelter, and funding in kind of the smaller communities? So just kind of a brief answer would be great. We'll start with Dr. Prest, first, and Ms. Dutson and Ms. Hatch.
Can you rephrase the question?
I'm sorry. Yeah, Prest, what are your ideas for overcoming some of the barriers that we've talked about a little bit, including limited resources, available shelter, and funding in some of our smaller rural communities?
Okay. I guess I can only, really speak to the problems I've seen in my life and the kind of focus that we've had here, I suppose. But, I think the biggest strategy that I mentioned before was collaboration and networking and bringing all the partners to the table. I think a lot of things get a lot clearer once you hear multiple voices. I think we've worked really hard to explore and get creative with funding sources. And that means, hitting up everybody for, the spare change that they have, as well as, finding champions. I would say, I think you need to, find champions within your institution as well as in the community, and invest in those people, and empower them and show them that there's hope that this could work this time. I think we need to make sure that we're really putting efforts toward empowerment on an emotional and psychological level as well. But I can't say there's much else besides what we've already mentioned that is worth hearing me say again. So I'll leave it there.
Yeah, I would say ditto to everything that she said. I think we've covered some of those bases, and to reiterate that part about apathy, that's a very real thing. And especially if somebody's come in with a lot of passion and gung-ho and maybe things fell short or couldn't get the support. Well, it doesn't mean that there wouldn't be better support a year or two down the road, or with a different champion now on board, or funding that's now available through the Chamber of Commerce or through the school district that just got another grant. So to be aware of the different catalysts in the community and staying fresh with that. Things are constantly evolving and changing. And I think it's another reason why that collaboration is so important, so that you can all feed off of each other's energy and keep each other motivated. And along with that too, I think it's important to stop and celebrate the wins along the way. It can be really easy to forget how far we've come. And the progress may be slow, but there often is progress to acknowledge and recognize. And sometimes that can serve as fuel to keep things going.
And I'll be real brief on this. Work with your coalition. Let's not duplicate services that aren't being filled already. And let's enhance what we have and keep our funding secure.
Great, well, thank you. I'm just going to go to Cris really quick, see if there's anything else in the comments section we should speak about.
So there was a question in the question and answer box that I think was from the previous presentation, but I thought we could just end with it. It's a good point. So what kind of resources, because since this is the prevention panel, what kind of resources in educating parents or caregivers around Narcan and tools they can use to educate their children? So any ideas, parting words for parents with children?
We just had a Facebook Live event through our hospital on Narcan and fentanyl, since we're seeing a lot of fentanyl rise in our community. And so I think, you know, we've tried to use our platform as the only hospital in the area to help, you know, spread the word. We've put articles in the newspaper. We've invited the schools. We've tried to, we're hoping anyway that we can get Narcan training within our schools as well. Narcan is expensive, but our health department, utahnaloxone.org, and then it can be purchased by your healthcare facilities as well. And making sure that you offer opportunities for parents to come in and get trained and understand Narcan as a harm reduction method, and the importance of, you know, having Narcan or dealing with a devastated outcome, I think makes a lot of sense to parents. So education is power, but also providing access to that education is vital.
Yeah, once again, I think she nailed that answer. Working with local health departments can be really helpful to get some of that information out. I would just add to that again, we need to be careful in some of the social norming that maybe we're doing, because while we want this information to be available to everybody, we want to be sensitive to the fact too, sometimes people, if they're inundated with information, you know, say if they're feeling like, well, does this mean everybody in my community has an opioid addiction? You know, we want to be sensitive on how to help those that are struggling, and to be sensitive and to give them every resource that they need. And at the same time, help those people, help the population understand that we can create healthy communities and avoid these substances altogether. I would also add that those that are in recovery, I have found to be the most passionate preventionists. They're passionate. They've paid a price for their experience, and they want to help people change. And often the same skills that they're learning in recovery are the same things we teach in prevention. Things about refusal skills, how to manage stress, how to manage anger, how to make clear choices. And so as they share those skill sets that they're learning in recovery, that can go a long way to protecting their own families and building strength in their communities.
Okay. And I'm just gonna state something that Heidi, or just talk a little bit more, is when our area opened up the first sober living, the first thing that we did was to invite that population into our substance abuse prevention specialist training, because the passion that they have to make a difference when they first enter recovery is unmatched by any other population. So make sure that they know how to do it right, and you're going to have a prevention crew that's going to be unmatched.
Okay, I guess we're going to have to leave it there. We really do appreciate you all participating, Ms. Dutson, Ms. Hatch, and Dr. Prest, and also for Dr. Meier for participating with us as a panelist. We hope you enjoyed this. Please come back for more as our summit continues. Thank you all.
Thank you so much, everybody. Well, we are coming up on our lunch hour, so I would like to actually turn it over to Kara Murray, who I'm going to, can someone promote Kara to a panelist? There she is. Kara is with USU Extension, and she's going to introduce our something fun that we're doing during Summit, the Goose Chase game. I'll let you take it away, Kara.
Thank you for that introduction. The Goose Chase is now open. So Goose Chase is a scavenger hunt that is played on a tablet, on your phone. It's a free app. You download it from the App Store. You can play as a guest, or you can create an account. The name of this Goose Chase is Troy Summit 2021, and the code is B5K8PX. and everybody should have received these instructions as well. So I'll just go over them very quickly. We have some really fun questions in there. Some you type in, answer a question, some you post a picture. Some of them are going to be, the answers will be given during the presentations. Some are just fun, different, silly things. It closes tomorrow, or I'm sorry, the 20th at noon, and we will have prizes for the top 3. So get out there and have some fun, post your pictures. You can look and see what everybody else is doing and get a good laugh, or at least bring a smile to your face. So we hope everybody will participate in the Goose Chase and just add a little extra to the conference.
Thank you so much, Kara. If anyone has questions about the Goose Chase, feel free to get in touch with any of us. We can help you out. Now I'm going to hand it over to Claire, who will review what to do next.
Okay, great. Thanks, Keady and everybody. Thanks for joining us this morning. I feel like I've learned tons of stuff that I'm going to have to think about for a long time. So hopefully you guys have all learned some helpful information this morning. So as far as the rest of the day goes, we are having kind of a lunchtime activity break from 12 to 12:50. We have 3 different activities, well, 2 different sessions during lunchtime, and then also time for you to like go outside and take a walk or work on some submissions for the Goose Chase scavenger hunt if you're interested. Our first session, actually, let me just bring up that screen so that we can see it. We're going to have a healing trauma art workshop is one of our sessions. And then our second session is going to be a create better health kind of lunchtime activity. So let me share the screen with more information about those. After our lunch hour activities, we will have 2 different breakout times this afternoon. The first time is from 1 to 1:50, and then the second time is from 2 to 2:50. The information about those different sessions were in your reminder email. We also have a list of those sessions here. At 1 o'clock, we have 3 different sessions. One is an intro to yin yoga. One is strategic communication, is that a thing, which Dr. Sulzer mentioned this morning during her introductory remarks. And then we also have a session about the grief of overdose death by Dr. Supiano. And then at 2 o'clock, we have 2 sessions at 2 o'clock. One is a naloxone education and training session, which we actually just talked about in our last panel. So if you are interested in learning more about naloxone or how to administer it and in which cases it should be used, that would be a great option for you. We also have a session about certified peer support, which we've talked a lot about today, the importance of having peer support in recovery. So if you're interested in learning more about that, we have that session as well. And I will put the links to all of these meetings in the chat box momentarily. But before we disperse to our afternoon sessions, we started out this morning by asking what something that inspires you is. And I would just be interested to know if there is something that you've learned today that has been inspiring to you this morning. So if you have a second, please put that in the chat box before you leave. And we'll leave this webinar room open for most of the afternoon in case you have questions or want to hop back in and chat for a minute. Just a reminder that our peer support room will be open until 1 o'clock, so you're also welcome to join in there. And I will put those links back in the chat box as well. So Keady, is there anything else you'd like to mention before we head to lunch?
That's it. Let's do lunch, and we'll see you soon. Thanks, everybody.